So we're going to talk about linear strip excision or strip cases. This slide you've seen 2 to 3 times before. It's just reminding you the good and bad candidates for a strip. Obviously, someone wearing their hair long, if they're women, they have low contrast in that scalp to hair to make that scar a little bit more difficult to see. Low shingle means the hair is going down. All of those people, or all those cases are very ideal. So as you know, exclusively for women, I do a strip. For extensive baldness, I do, for the most part, exclusively a strip. And you know, when I'm always worried about that crown, when I see extensive crowns, I'm very, very hesitant to do an FUE because that donor is either compromised now or it will be compromised within 10 years. And that's what I'm very nervous to go and harvest off the backside because I have to, by nature, with FUE, harvest whiter. And then it's not all or none. You know, so I really believe that even though you've seen these slides 3 times, redundancy is really a key way to deliver that message to you. So you understand when you hear something 3 times, it's probably pretty important, okay? And this is an algorithm of thinking and an algorithm of communication. So what we're going to do is plan the donor. There was a question earlier in the course yesterday about, you know, what do you use to determine areas in the back? So I use bony landmarks as my first go-to. And so what are the landmarks? You guys know this already. If you don't, we can do this in lab. I'm more than happy to feel these landmarks with you guys. But basically, there's the bony protuberance in the back, the occipital protuberance, and that bottom edge of it is the superior nuchal line. That's sort of where I usually start my thinking, okay? I rarely go below it. This last week, I went below it to the inferior nuchal ridge. I don't often go down low because there's more nuchal musculature coming up. So you worry about wider scars, you worry about tension pulling down, you worry about retrograde hair loss coming up, causing problems. So you don't want to go that low in the vast majority of cases. But if there's good laxity, there's no retrograde loss, they've got a good enough age where you're not worried about that as much, and you want to take that best harvest low down, as I told you sort of in lab and it'll be reiterated in this lecture, you get the highest point of tension at the lowest time of tension, which is the first case. At the highest point of density, you can almost do closer to what, like that FUE thinking. Remember, what the reasons oftentimes I do FUE is they got such a long nuchal zone that I can't take that with a strip. I'm going to lean toward FUE in that case. In this case, I'm going to try to steal down low if I can get away with it. That's an advanced thing. If you're going down to the inferior nuchal ridge or below it routinely and you're starting out in your career, I have taught you wrong. This is just, but I want to mature your thinking into sort of long-term creativity. But you want to stay probably no lower than the superior nuchal ridge in vast majority of cases, okay? And then the mastoid is really just that very low outer portion. If you're touching the mastoid and you're harvesting from there, in general, it's too low. It's high risk of exposure. But if you feel the mastoid as you go vertically upwards, that zone is the point of highest tension. Along that sort of lateral area, and you can feel it, it's tighter. Okay, so the lower you go, also the tighter it is. I don't use laxometers, or there's so many different ways. The classic one is the Meyer-Paul's or Mayer-Paul's technique of looking for glidability and looking for tension. I just feel it. And to be honest with you, if you don't know how to feel these areas, we'll go feel scalps together. I'll tell you this one's tight, this one's looser, and that may be obvious, but nothing is obvious until we do it, right? So I'm more than happy to do that in the lab with you guys. The big thing is DUPA, diffuse unpatterned alopecia. This is a gentleman that showed me that was offered an FUE case by another company in Dallas, and you know what? This guy has unusable hair. It's miniaturized all over the place. And when it's that level of miniaturization, you know that hair is going to be gone after the transplant. You know that's going to reveal scars. You know he's going to go to diffuse, probably Norwood 7. So when you're looking at the donor, look for miniaturization. I don't want miniaturization above 20%. Even 20% is pretty darn high. But if you're looking for if you don't know, you can't see miniaturization, get a densitometer, get some kind of follicoscope, a dermatoscope, look carefully, start to understand what miniaturization looks like, or vellus hairs look like. So palpate the bony landmarks, feel where they are. That's how I start my analysis, and then I look. So that combination of feeling and looking is so important. So just a superimposition of superior nuchal line, you can see it's just in that zone, somewhere in that area. And again, I'll be more than happy to show you that in lab if we need to. So I first mark out the superior line. And that just tells me, okay, this is where I want to go. And then on the lateral limit, where do you go? How far do you go? How high do you go? 2 to 3 finger breadths is a good idea, so you can stay consistent with both sides. But to be honest with you, it may be too high in certain cases, maybe too low. I'll just use that as a general guide. But you need to look at the zones of miniaturization. I'll be happy when we start doing this. The first part of the lab is we're going to look at some donor scalps, and I'm going to show you where would I mark out an incision on some live patients, so that you sort of understand that, because you get so focused on how do I make a cut that you don't even think of where do I cut. And to me, where do you cut and how do you cut are equally important. And so that's why this first part of the lecture is decision making and how to make that design. So then I just draw out that superior line laterally, and then I basically connect the two to join those two. That's again the superior line. And then I'm going to just do the contralateral side, same technique, but it's not always symmetric. Sometimes there's miniaturization going lower or higher. Sometimes I can't go as long, especially when you're dealing with a younger patient. I rarely go beyond the helix because that's where things become problematic. There's more risk of showing things up. You know, as we get older, there's recession. You show up the scar, you have problems. When I'm over 40 to 45, especially 50, I start thinking, can I go longer on it and harvest more to get the best areas? Now, I'll be honest with you, this area is very dangerous too if you're new to this, because the superficial temporal arteries there, the distance from subcutaneous fat down to the deep tissues is negligible. You can easily transect, go too deep, and cause major neurovascular problems. Okay, I've transected STA early in my career. The person had incredible insane influvium. I show that case in the new book, the 101 book. So this is an area it's harder to harvest. But sometimes you've got these guys that only harvest the occiput. They're burned out, and they've got these gorgeous bitemporal zones that can be taken. So, and there's no laxity left back here, and this is perfect. So I'll do that, as you saw some of the cases I presented with like an FUE beard, and it's just a great salvage case. So plan the width. Now, how do you plan the width? So I'm harvesting usually standard about 1.2 centimeters. To me, that's too wide for most of you. I wouldn't go wider than 1 centimeter. And remember what I told you: go short, go narrow, and try a little segment. See how your staff are dissecting. You can easily harvest 30 centimeters. The question is, can your staff dissect 30 centimeters? That's the better question. So if you harvest a small segment, let them work with it, and they're doing great, and you're following their progress. You can always come back and harvest more. You can do it the second day. Don't go crazy with a long harvest because you've heard this presentation. You don't think about the other side, which is the assistant side. So this is not how I do it. Okay, this is how you can do it. And so as you heard, what I do is I find the best donor if they have a large area loss. I want to get as much donors as I can to transplant, so long as it's safe. But sometimes I wind up with 3,000 grafts. Sometimes I wind up with 2,100 grafts. I just want, as I told you, I don't charge per graft. But another way you can do it is use a densitometer. You even just have one of these that little thing from Trivellini. Look in there and measure how many follic units per square centimeter. And then let's say you're doing 1 centimeter harvest. Well, if it's 70 follic units per square centimeter, you're doing 1 centimeter multiplied by 30. You have a projected maybe 2,100 grafts. It's a way to project what you're doing. Again, I don't do it that way, but this is one of two ways. You can either project it and think about what you're doing, or you can sort of estimate, look, I want this harvested, and then your staff will calculate for you what is actually harvested. I'm going to show you how to do that as well in a moment. So measure the length, and then I like to report that to my staff, and it just sort of gives them an idea, and they're going to measure it again, but it gives me an idea of how long everything is. And I mark out the bottom line based on sort of how wide I want it to be, and then I just taper out the ends. Okay. So then I'm going to prepare the donor. So this is even something that people think, well, why are you even showing this? Because you guys need to see every part of this. So what I do is I use short pieces of tape. The reason for that is it's easier to tape up the area. You can basically use like a rat tooth comb on the backside, pull up the hair, and then apply it With African hair, it's actually really good because it just stays up. You just pull it up and it just stays up. It's really elegant. Otherwise, you got to hold it up, and then you just finish the tape all the way across that area. Once it's all taped up, then you go and shave it. Remember what I said for this? I like to see the hair curl, so I leave it a little bit longer with the 2-guard, so it gives you about 5 or 6 millimeters there, and the hair curl helps my staff know how to direct the orientation of the graft. And then my staff, this is what my staff does to prepare it after I determine where I want to harvest, and then I've already finished the hairline. I walk out of the room and they're preparing this and getting them ready to go. So this is my staff doing this, and so they're just combing away all the excess there, and then they just tape the bottom in the same technique that I just showed you, and then they take that little cape that has all the excess hair and throws it away, and then my staff just uses a tape to pull off any of the extra hairs. And this is all these photos are not only given to you in the video format, but these are all used in the book. They're taken from the book, so this is all placed in with a long narrative description, so that it'll be a great exposition for you guys. So this is the Curlex, and so essentially you're folding it multiple times back and forth on each other. That way you put that onto the donor underneath where you're going to harvest, so it collects any of the soilage or blood that's coming down. You can also put a few in the front if there's some recipient areas. In other words, double up on it before you do the final wrap around the head, and then just tape it in position there. Look anesthesia, you've already heard it in the lecture. I think it's worth just reiterating a few points. So you know that for me, I always start with the regional block once I've gotten some sedation. I like doing the regional nerve block first. There's a review. The supraorbital block is going to hit the medial hairline up to the top of the occiput. The auricular temporal block, which is just above this ear, again, I can show you that in lab if you want, is going to hit sort of the lateral hairline. And then anything below the lower portion of the temple, like the lower half, you need to do is zygomatic-temporal to knock that out. To repeat, the regional nerve block is not going to provide perfect anesthesia for the front. It's so that they last all day. I rarely, if ever, have to come back now and retouch up a block by midday. The ring blocks oftentimes is a standalone fail. By midday, there's a little failure, and then I'm out of the room ready doing something else, and I can come back in and they're awake and it hurts. It's best to knock them out with these nerve blocks. They stay really durably if it's done well, but always withdraw, because if you're intravascular, 1 cc of bupivacaine is fatal. So be very, very careful. You always withdraw. You are near arteries on all of these things, and that's something that should be obvious to you. If it's not, don't do this, okay? Always withdraw. Yes?
Do you have supratrochlear nerve block?
So that's what I was mentioning yesterday. Supratrochlear is irrelevant, and the reason why. So supratrochlear, as you know, you basically pull out and you go very superficial. You don't need to do that, because if you look at the anatomy of the supratrochlear, I've heard my hair surgeons say, oh, do a supratrochlear block. They're wrong. Supratrochlear blocks end here. Go look at the anatomy. It's this zone the supratrochlear hits. You're not putting hair here, okay? If you're doing an eyebrow, you're not going up here. You're only here. The supraorbital is still going to nail this. So you do not need a supratrochlear block, okay? Good question, though. So then I do the ring block. You heard what I just use a 1% lidocaine to 100,000. I start posteriorly, go anteriorly. I'm using about, maybe 15 cc's or so to hit the whole head. Sometimes you need about 20 cc's in there. And then, as I said, if your patients are really more awake, try to do these little droplets and then follow it with a larger block joining those little dots. It makes it more painless for the patients. You can always use like nitrous gas if you need to. This is so key. I'm going to try to direct you to the slides that are the key. Tumescent anesthesia or tumescent fluid is so important for the following reasons. What it's going to do is going to provide ship over coral, which is basically, as you know, high tide. That ship is your blade, and the coral is going to be your neurovascular blood supply. If you pull that fluid between the two, you'll have the following benefits. One is very little discomfort postoperatively because you're moving it from the neurovascular blood supply. Second of all, better healing because the neurovascular blood supply is intact. Third, and that's going to be predicated on also how you harvest it. Third is hopefully there's better graft survival because the blood supply is going up to those grafts. Fourth is it creates a little bit of mechanical creep, because you're placing it into that area, maybe just about a centimeter beyond it. So that helps expand it, and that allows it maybe to relax and come down a little bit. And then another very important part, and one of the biggest points of the whole reason, is minimizing transection. And the reason for it is that think about these grafts, these follicles that are really close together. You spread them out. It makes it much easier to harvest. Also, hemostasis. If you have blood everywhere, you can't see anything. And just 1% lidocaine ring block, it's going to be bleeding. So if you place that tumescence in, and sometimes I'll be harvesting and blood is coming out a little bit, I just put more tumescence in to tamp out that area before I continue harvest. If you see a lot of bleeding, you haven't put enough in. Put some more in, take a second. That few seconds of extra tumescence is going to save you transection and time and everything else. The other part, I talk about all this in the book, is also if there's slivering, which is the first act of cutting, like you think of a bread loaf, you're cutting it this way and then you're making graft dissections. The slivering is significantly aided by your tumescence because the follicles are all like this. Sometimes they're crossed over and they become like this for the sliver. So they have a much easier times. So don't just place the tumescence on the proposed incision line, which I'll show you, but also place it throughout in a uniform fashion. So you want that area blanched, not blanched 100%, but some level of it's flat. And think about this, if you're just doing it to the edge, it's going to curve off. You want it flat all the way across, just a little bit beyond the borders of where you're working, so it's all flat and tight. Sometimes you put it in and it's starting to drop down very quickly, and you need to go back and add more. So what I usually do is I go ahead and just add maybe like 50 cc's across the entire backside. Then I come back and I'm going to harvest a third of the incision. So I'm going to go back and really hit that hard, harvest that first third so they can begin the calculation, and then I put more tumescence on the rest, and then I harvest the last 2/3. But if I score it after I put the tumescence in, it expands that area and then it contracts back down. So I actually have too little. So I like to score before the tumescence, and those are all the reasons why I've segregated that. And, does that make sense? Okay, that's a fantastic question.
Are you waiting like 5 or 10 minutes for the epi to kick in?
No, you want it. If you wait, the tumescence is fading because you've already got because it's the tamponade is that so powerful. It's a great question. I want to start immediately, and I'll be honest with you. By the time I finish that whole area, I already have 5 minutes transpire, 10 minutes transpire. Okay. Let's talk about how I do donor harvesting. So the first thing I just mentioned here is dermal scoring. So what I use is a multi-blade device, and I put 15 blades on them with a spacer that tells me 1, 1.2, 0.9, whatever I'm proposing is my width. And I'm only just putting, you're going to see, I'm going to actually do it with you so you can see this. I put the spacers on there, and I place just a little exposure, and I just score the dermis. That gives me a lot of benefits. So I don't believe in multi-blade harvesting. I used to do that, but when you start understanding, when you have two zones that are more than about 5 millimeters, the angles are different. When I'm harvesting, I will have different angles throughout, and each angle is different. So if I have a multi-blade harvesting all at once, like this, I think you're going to have a higher chance of transection. So I always harvest with a single blade, not with a multi-blade device. However, the multi-blade scores it, and it gives me a lot of advantages. One is I get a very uniform width. I know exactly the width there that is versus a hand drawing is not that accurate. Second of all, it allows me to put extra tumescence right in the incision line where my blade is going to cut. And third of all, if I'm looking for graft calculation, if I don't have a perfect width size, the graft calculation will be off. Okay, because here's how much off are you? Well, you know what? When your blade moves, you're going to be a millimeter off somewhere. Okay, and then wound healing is now if you actually harvest 1.4 when you actually wanted 1.2, if you're off by 1 millimeter on both sides, you're going to have maybe closing tension you want, especially in the area like the mastoid region, right? So for all these reasons, I like scoring it. All right, I'm going to show you how to do that in lab, how to even set the spacers and do all that. I'm the only one doing this probably, so you're going to hear my philosophy only. And if it works for you, great. If it doesn't, And then I harvest. Okay, you always harvest from the bottom 1 one first because the blood comes down, the tension's there, so then you go to the top one to harvest. But this is the slide that I want you to know, and it's in your handout, it's in the textbook, even the photographs are there. So this is the most confusing thing. And a lot of people, especially if they're not surgeons by background, all they care about is how do I handle the blade, which I'll be happy to go through that with you. But what's more important is, are you seeing transection? So it's funny when I teach this course to non-surgeons, they're scared of everything. When I teach surgeons, they're scared of nothing, and they want to just show me they can slice it. But surgeons don't think of transection. Non-surgeons don't think of transection. No one thinks of transection. But this is the thing you need to think about. It's the most important thing. I'm talking about not only transecting follicles inadvertently, but neurovascular blood supply is because you may get it perfect, but you're going so deep, you're now going to galia. That causes serious problems. You should be at the base of the bulb, and that's it. So you're adjusting angle and everything else. And what are these angles? Okay, here's the trick. This slide, hopefully you can see it, is a little bit busy, but it's, trust me, I work a lot with this illustrator to get this right. So let's go through this. If you're seeing no transection, which is in green, we'll start with that in the middle. You're going to see the whole hair shaft from bulb all the way emanating out of the skin, and that means you're good. Okay, that means your blade angle is correct, and you should see it with there's no cutting right now. If you see a cut in the upper portion, so let's say, okay, here's a wound edge. We're talking about the inferior wound edge. I can't see the superior wound edge. It's the inferior wound edge. Okay, does that make sense? When I cut it open, it's the bottom portion I'm looking at. That's what I'm defining. If this is the hair shaft coming out, all right, this is the head. This is the hair shaft coming out. Does that make sense? And this is the air. If I see the cut up on the top portion, in other words, I see the bulb intact, most of the shaft is good, but then I've got this cut on the upper portion. I will tilt my blade down a little bit to make the adjustment to minimize how much you tilt, just a little bit first, and then see if that's enough. And that's why you go very slowly. When you see me harvest, it's not a whoosh, because I'm sometimes making micro adjustments. Sometimes I go and it's just smooth sailing. Sometimes it's not. But even if it's smooth sailing, I'm still going very insanely slowly. And insanely slowly, I'm still done like this. Okay, so please don't. If I see you in lab going this, it means you missed the whole point of this lecture. It's not how to put a blade into a head. It's how to minimize and avoid transection. You're gonna have some transection. It's never zero, but as close as zero as possible with adequate tunescence and blade control. It's gonna be great. So I have a blade. I don't know the brand. I should look this up. I don't think it's in the book. It's a rounded handle. It's really nice because I can make adjustments really nicely on there. But so basically what you're doing is I have a staff member on my right holding up double hooks. I am they're dabbing and I'm constantly checking. And so if I see the upper shaft, my mnemonic to make it easy so you can even think about it. If I see upper shaft cut, I bring my handle down, which makes it tip up. So if I see up, I go down. If I see down, I go up. Make that easy, okay? Like we went through med school. I'm sure all of you have a million mnemonics. Randy Travis drinks cold beers, whatever that for the Ray, right? You've all got mnemonics. So I'm giving you a mnemonic to make this not so like, oh my God, what does Sam say to go up or down? So on the opposite, if you're seeing a bulb transection, in other words, toward the bottom third, if you're seeing it closer, the transection occurring closer to the bulb, okay, that's the bottom, you're going to move your hand up. Even though the blade goes down, your hand is what you worry about, right? So I think in my hand. So if I see a low transection, I'm going to move my hand up to adjust. And you're going slowly looking for that transection. So this slide is the most important slide of the entire lecture today. If you think about how to handle a blade and how to make cuts, great, but this is the slide. You must know the slide, and that's what we're going to be testing in lab, okay?
Are you wearing your high power or your low power?
Great question. I'm using low powered. I only use high powered for when I'm doing FUE. However, I do have a 4.5 that I used to use for FUE, and if I have white hair, which is transparent, and it's really hard to see, sometimes I'll pull my 4.5s out. But generally speaking, the 2.5s are good enough. Even if they have every third hair dark, it's enough for me to see it. I don't need to move out anything but my visor. That's a good question. All right, so anyways, so I incise and I harvest a third of the strip so I can get it out and give it to my staff. And so what I do is this is an older slide, I use just a towel clamp to pull it forward, and I'm dissecting with like a Metz, and if I see a vessel, I'm spreading, and I'm very careful to get it off any blood vessels because you don't want to transect blood vessels. I rarely have ever cauterized. You want to be really, really, really careful with that. After I've harvested the strip and handed off my staff, I can do a trichophytic closure. The trichophytic closure essentially is taking about a millimeter off of the bottom lip. That allows the hairs to grow through the scar, which makes it harder to see. It creates a blur. You don't want to do a scar revision with weird geometric broken lines. That would be a big disaster. You just want to do this. Now, when do you not do this? And my towel clamps feel like there's a little bit too much tension, you should never close tension, then I will not do trichophytic. Or African Americans worry about like kinkiness getting into the wound. I don't do it in African Americans. I do it basically, or sometimes women, if I feel like, you know what, I've harvested whiter, I want a really good strip in the middle. I usually don't do that, but for most men, I do that, okay? But if there's not enough tension, you really should not have. If you have worry about tension, don't take the whole strip out 5 ounces too much. Take a little bit out, just don't even move it, and just make sure there's not much tension. You always can either put it back in or stop the procedure, but if you cut the whole thing out and you can't close it, you're in doo-doo land, right? So you don't want to be in that situation. So then after that, I just remove a little hair debris using very, very tiny forceps and under magnification. I put in my towel clamps to decompress the area and align the wound, and then I close the incision. The way that I close the incision is I grab about mid-follicle. You don't want to go deep for a lot of reasons. It can ensnare the hairs, it can grab neurovascular supply, cause a lot of pain, and I'm going about 45 degrees across, because think about this, when I go 45 degrees across, first it's a lot easier, but the loop that comes down is 90 degrees down, okay? If you think about that, you can see it here, and that draws it down over the trichophytic edge. You want it to draw down over that raw edge you've exposed. And here's this dirty secret. You need to pull with a little bit of tension on the wound, okay? Now this is counter to surgical technique, because now you don't want tension on the wound, don't get me wrong. Oh, that's a 309 nylon or 30 Prolene. Either one works. The trick is you want to pull with a little bit of tension on the closure. The reason is that it's with an incision, a horizontal incision with a vertical drawdown, and with fluid dissipating, it can loosen a little bit. And so what I've noticed with wider incisions is due to the fact that you haven't closed it with enough force of the tension. Now, how much tension? I have to show you probably in lab. There's a little bit of I'm not talking about strangulation. It's just a little bit more than you would on a facial closure or on something else. Okay, I don't do body works. I don't know that.
You ever have to undermine the blade?
Great question. I had one disaster of a donor. It was an undermining, and I undermined it subgaleally, which if you're a general surgeon, you're thinking, come on, subgaleal. You rip out all your blood supply, you get serious problems. Now, there have been discussions about doing a little bit of tunneling, where you can put little tunnels in there to help improve it in the subcutaneous plane without damaging neurovascular blood supply. I've not really had to do that. What I always do is always double check to make sure there's no tension. I put towel clamps so I can. I give it time for it to close. I also, hyaluronidase is, I think I have a slide coming up in a minute, is helpful. Hyaluronidase is, I can't guarantee it's going to actually improve the situation, but you basically take a full bottle, 150 units, put in like 5 milliliters of saline, and just inject about half a centimeter above and below the wound. Sometimes you can use 2 bottles. And within 10 minutes, the wound tension should reduce. But that is a salvage. You don't want to be using it. I use it a couple times a year. That's already too much in my opinion. I'm misjudging it. So you want to be very, very cautious with tension. You don't want to use hyaluronidase all the time because that's what your exit is. That's a salvage situation. So, Undermining means if a wound edge is like this, you're cutting below the wound edge to take tension off. Okay, so it's a basic surgical technique, but it's a technique that it should be, in my opinion, not performed at all, or very, very rarely in a very select way in strip harvesting. So then I come back after I'm done and I put the bupivacaine block around this. The trick with the bupivacaine block is I don't just place it underneath, I place it through the incision, a little bit above, a little bit below. If you go through it with about 12 to 16 milliliters in the incision, you have much less discomfort than just placing it below. Okay, so that's a little trick. Then I come back and I do the same nerve blocks that I did initially with bupivacaine. Again, I just warn you, intravascular is very dangerous. Make sure you have withdrawn. Then I do the recipient tumescence into the area. And this, remember, is basically dilute lidocaine, but the lidocaine is not really critical because they're numb. It's really the epi, and it's really the fluid that's helping to move that away, that ship away from the coral. In this case, would be recipient side away from the underlying neurovascular blood supply, especially midline, which is where there's more tenuous blood supply. And it's also that triamcinolone, the Bossi formulation, is to help minimize postoperative edema. So you need to really use a lot of sequential tumescence, usually between 30 to 60 milliliters, so that you protect the neurovascular blood supply, because poor growth is due to long instruments, dense packing, and not enough recipient tumescence. So that's, to me, the big thing. You're going to hear, I've read this many times, that epinephrine load is really dangerous. That's going to cause the issue. I personally, when I go against the grain and say I don't think epi is the issue, I sometimes there's too much bleeding. I'll use a little super juice, which is 1 to 50,000 epi, either with or without lidocaine, sometimes saline. If they don't have cardiovascular issues, to do that. Sometimes if they don't have a contraindication of tranexamic acid or TXA, which is I will give them because they're intravenous, I give them a gram of TXA to help minimize bleeding. For me, I don't care about the bleeding so much as I'm making sites. I can work around it. I care about when they're replacing grafts. I don't want them to be dealing with a lot of blood. So the thing I want you to remember with recipient tumescence is protect the neurovascular blood supply. That's the reason I'm doing recipient tumescence and a little bit of postoperative edema issues, which is obviously still important. And then you test the graft to site fit before you begin the site creation, and then you begin this. Now, how many sites do you make? So this is the trick here. I'm going to show you this idea of how to calculate. So what they do is they'll take like a 4 centimeter segment. They may take it from because it's different from the temple to here. So I like to have a little bit of them to be able to take an average of this. So they take a segment. I'm just using this example. So from that segment, they've dissected 54 1 hairs, 222 hairs, 62 3 hairs. That gives them 336 follicular units, or 84 follicular units per square centimeter, because that's number is 4 centimeters, right? And then if I've harvested 24 centimeters, for example, they're projecting off 6 segments. 6 times the 336 equals 2016. So that's how they project the number, okay? And that's a way that I can know with a general estimation of how I can design into that. So that's the way that I do it. Does that make sense?
And when they're doing that,
Yeah.
aren't they always going to be a little lowish because you're going to that side?
No, so remember, I'm taking the first segment is all the way to occiput.
Okay.
So the trick is not just to take this. I take from this to here so that they can see the whole gamut to where it counts. Now, once you get to the beginning of that third segment here, it's the same from here to here. I just need to get into the central occiput enough that they can start their work. That's why I do the third, so they can start working. It just saves a little time. So I do 1/3 out, then 2/3 finish. Okay, but you need to get into the occiput. It's a great question. It's exactly why you need to go long enough on that. Great question. Okay, so this is just the hyaluronase. I already told you this. It's a salvage. Don't think of this as like if you're using hyaluronase in every case, you're over harvesting. Anyway, so then I just make the recipient sites after that. So you remember that FUE is reversed. This is, for me personally, again, this is you're hearing all of my biases. You're going to talk to 5 other surgeons and get completely different ways of doing things. And you're going to find what works for you. But I can only tell you what works for me and justify it through discussing it. So summary is always look for laxity, look for mineralization of bony landmarks as you're judging where to harvest. And we're going to work in that in lab, because before I show you how to hold the blade and how to look for transection, where do you put the blade? Where do you put the incision? Trust me, that's the first step. And a lot of times in lab, I've seen this taught, not in my course, but you've seen it where you're also diving down and cutting. And then when you go in to see a patient, you're like, where do I put this guy? Right? You need to know where to put the cut. And I'm going to teach you that. And then tumescence is a key thing. It's so critical for all the reasons beyond just neurovascular protection. Understand how to minimize transections is a key slide. Remember that slide. We'll go through it again. Hopefully, we drill in your brain that you've memorized it. Trichophic incision is helpful. By the way, I showed you the way, I didn't really mention it, is I just take the forceps, hold it up, and I just take it to 5 or so and just cut right across. You don't need, a lot of people try to make it perfectly even. You don't need to. I mean, if it's a little raggedy, it's going to close fine. I look at it like a scar, it's like a little regular, it's not going to be a problem. So that's my philosophy. You don't need a perfect edge or trichophic. And then close the suture with slight tension. For the non-surgeons, I think that's going to be particularly hard because you don't know what slight tension is. You're going to try to strangulate the wound, and that's not good. And you don't want to make it so loose and just barely kiss. That's what you do on a face. You don't want to do that with this, okay?
How are you positioning the patient? You put the towel?
That's a great question. They're sitting up. They're sitting up. They're sitting up for this part of the harvest enclosure.
Down or you're standing up when you do
I'm standing. So I don't like, so there's 2 ways to harvest. It's a great question. There's 2 ways to harvest. You can either go prone or you can be sitting up. Now I have this neck guard that holds their neck, and then my staff is further holding. So the negative of having, so the reason I like them like this, because first of all, they're under sedation prone, they're airways issues. That's why when I do FUE, I can't give them deeper sedation because they're like this and worry about airway. Well, if I'm doing this harvest, then I got to move them over around. Now for me, I just harvest sitting up, I put them flat. So that's my real reason I'm having them sit up, and I've done this for 20 years. So I'm so used to harvesting sitting up. It would be hard for me to get down and harvest prone, but you may find prone is better because you're not under, so the 2 ways to classically do harvesting, strip harvesting is prone or sitting, okay? And the pros and cons of both. You're going to find what works for you. But those are reasons I don't do it prone. All right, so we're going to go into a more advanced topic here, which is going to be non-virgin determination. Because remember I told you part of the battle is finding out where to harvest. Well, what do you harvest now that the person's had 3 strips? Even more difficult, right? No one talks about that, but I want you to think about this. So these are non-virgin scalps. So I'm just going to go through some basic points again. Remember the safe donor area is your guiding principle. It's guiding principle of where you can take, and you know that area shrinks over time. Okay, I hate to say it does. Look for those areas of coronet expansion. In other words, that bottom portion of the crown expanding. You know what that is? You'll see it in my crown lecture. Retrograde hair loss. We show some examples of that. The hair actually not just going down, but going up with loss. Look for subtle signs of diffuse unpatterned alopecia. Look for obvious signs that tell you, hey, maybe I shouldn't do a transplant, or maybe I should avoid this area. Okay, and remember that with FUE, there's a little bit more risk than a strip, but strip has its own attendant risk. Nothing is risk-free. So you've got to counsel the patient, but never counsel the patient where you offer them risk because you think, I really wouldn't even do it anyways. I never give a patient a surgery that I don't think they should have. I give a patient, if there's a little gray, I'm going to explain these are the risk benefits, but if I think it's absolutely white, black, or no, they don't get surgery. So make sure you don't give, because patients don't know. Your fiduciary obligation on that patient is not to do surgery on them when they shouldn't be getting it. Okay, and I spent a whole day on consults. I turn everyone away. It's depressing because listen, I'm in business, right? I need to make some money, but I do that ethical thing. If you need to turn them away, please do so. That's so important. And it's hard, right? You're getting money for this, and you're going to say I want to turn the money away, but it's the right thing to do for the patient. You never be ashamed of it. It's one of those things that inside I hope I ingrain in you social justice, which is to help people. That's the reason we're in this field. Okay, it's not just words I'm giving you. You can ask my staff if I turn people away all day long. I do, and then it depresses me when I hear they've been offered like a 5,000 graft FUE case when they're DUPA. Okay, it's like you got to be kidding me. You know why? Because the physician has left the room. It's salespeople selling it. They're on a commission, and that's the sad state of where we are in this world right now. They don't care about long-term problems, and the world is being destroyed. So what I'm creating, hopefully in this video series, and in you is a drive to be more ethical and a drive to do good work, okay? So anyways, so look for these things. We mentioned in the last lecture, redundancy is a key. Look for laxity, feel laxity, miniaturization, look at the bony landmarks, look at where the densest areas you want. That first pass when you got to hit that frontal zone, it's all about getting that nailed down. Subsequently, we may do small cases, but I want the best, densest, greatest area. And remember, I like to harvest low for the reasons I enumerated, and you'll hear more in this lecture here. So men, I usually harvest a little thinner and longer because I can do that. And with women, I harvest a little shorter because oftentimes their temporal hair is bad. It's not great. And I sometimes harvest a little higher because even though the scar should heal well, if the women wear their hair up, then it's just a risk that there's a scar visibility. But if their densest areas in the lowest part and they're good laxity, I may harvest low. And so that's important. Now, this is the principle that I've come up with and I've talked about in the book. I don't think it's really presented elsewhere. But I harvest in the highest tension first, and that's usually low because it's several reasons. As I told you, as you do more and more surgeries, they're going to get more and more tension. So I want to continue to go to lower tension zones, right, when there's more tension. Does that make sense? And I also want to harvest in the highest safety. Where's the highest safety? The farthest away from the crown, right? Because I'm harvesting near the crown. Well, first of all, let's say it's 10 years later. They're 40, now they're 50, coming back from another surgery. Well, 50, and I look at where their photographs are over 10 years, the crown is stable. Hey, I feel more comfortable going higher and higher. You see what I'm saying? It's always a risk going higher. But now you take that risk in a delayed fashion rather than early. Does that make sense? Those are the two reasons I start low if I can. So then here's the controversy, okay? You're not going to hear this from another lecture because I've actually presented this to my colleagues and they're all quiet. I'm not quiet. I want to tell you the truth here, which is the idea that you can do beyond a single scar. You can do multiple scars, all right? But here's the problem, okay? Multiple scars in beginner hands is very dangerous, all right? And that's the problem. I present this and present all this information to you because I think it's good for you to know where you could potentially mature to, but I would really encourage you to stay with single scars. If you do multiple scars and you don't know what you're doing, you just transect the blood supply 65 times, you have a completely decimated backside, and you have real bad cosmesis. So you really probably should stay with single scars, at least your first 5 years in practice, and then as you start to think, you can go to multiple scars. But how do you do multiple scars? Where do you place it? That's what this lecture is about, okay? Because single scar, I can tell you, just go take the same thing, right? There's no thinking. So we're going to talk about an algorithm here. So single scars, it's the same algorithm you saw. It's the same idea that with FUE, you don't want to have a visible scar, but if you've got a white hair, older person with laxity, I have very low tolerance to say not go to multiple scars because you can't even find the first one to begin with. So these are the things. And what is the benefit of multiple scars? Bigger harvest. Whenever you take out a scar, you lose harvest. Now, how much do you lose? That's the next topic. So strip calculation of virgin scalp, we just went through the slide, okay? You know it already. I just showed it to you a few minutes ago. But what happens when you've got a scar that you have to remove? Well, it's pretty simple math. So let's say the scar is 5 millimeters wide and it's 18 centimeters long out of the distance of the 24 centimeters, right? So you know that it's 1 centimeter minus 5 millimeters, which is basically 5 millimeters of usable tissue for that distance of 18 centimeters, right? So that means that 84 follicular units, which is your native non-scarred zone, really drops down to 42 because it's half. Does that make sense? So then if you look at the scar segment, it's 18 centimeters times what you have left, which is 42. And the virgin segment, which is 6 centimeters, there's no scar in that area, multiplied by native 84, that gives you 76 plus 504, gives you 1260 grafts. Remember what we showed you in the previous slide is 2000. That is a reduction of 38% with a 5 millimeter scar. Now, 5 millimeter scar is not great, but this is, so you think, well, just take the scar out, and all of a sudden you have not enough to make a transplant because you didn't calculate how the scar is taking away from your total numbers. So that's why it's great not to take the old scar out because you get more numbers. But sometimes it's worth taking the scar out, sometimes not worth taking the scar out, and this is the algorithm here. So what is the algorithm here? So the algorithm to talk about this is, now this is very, very advanced. So why am I presenting eyebrows? Because you need to see everything, and then I tell you, don't do this. And that way you know the context. You need to have the cerebral, cognitive, encompassing knowledge, and then know where to navigate, right? Because you don't know what you're doing. You're going to go into this water thinking, well, Sam didn't really tell me about that idea, it's fine. I'm telling you what to do, what not to do, and how to do it. So these are advanced ideas. All right, so if the scar is really hard to detect, and patients fine with the idea of a separate scar, you need maximal yield, don't worry about the old scar, take it somewhere else, okay? Where do you take it? Again, based on laxity, density, miniaturization, bony landmarks, all those attributes. And you want to hopefully be at least 5 millimeters, if not a centimeter away from the old scar, preferably a centimeter, that way you don't have the scars merge, okay? But this is again advanced. Now, what if it's a thin prior scar? It's 2 millimeters. You see a little less than 2. You can see it. It's barely there. If you comb through it, you can see it. Again, it's the same thing. It's pretty small. If they've got good shingle, good density, and they wear their hair a little bit longer, and you need a lot of grafts, I take a separate scar. I'm not worried about it, okay? Because it's too thin to actually bother to transplant in that area, but it's fine. Let's get maximal yield. And that's a discussion you can have with the patient. If it's 2 to 4, now we're getting to a zone that's not quite as good, all right? And if you need maximal yield, and that's the thing. Think of this. Would you accept a couple not so perfect scars if you have a lot of hair and you wear your hair long? To me, it's a worthy choice. But you know what? That's a choice you got to make with the patient, so that they can think, okay, that's a good battle. Some people go, no. I sometimes wear my hair a little shorter. I don't really like the scar right now. I don't care about more hair up here. I just need to get the scar better. That's the discussion you're having. At 2 to 4, it's not a great scar, but it's not a bad, terrible scar. And so this is where that judgment is starting to grade. Now, when you start to get 5 beyond, that's not as favorable a scar. So now you got to start. But then, as you know, when you start getting that wide, the problem is 2 things. One is whatever caused that scar, tension, not good technique, whatever it may be, is going to reproduce that scar with a second excision. So if you just cut that 5 millimeters out, here's the real truth. You'll probably get another 5 millimeters, and you're not going to have enough grafts to transplant. That's a dirty secret. So when I'm at 5, I usually don't remove the scar. Honestly, I harvest it somewhere else and I transplant into the scar. Okay, that's a very, very advanced thing. In my opinion, you should probably look at either FUE or just harvesting the old scar and having a less of an outcome. But whatever predisposed to 5 millimeters probably would again. And that's the problem when you're looking at a potential scar revision. Is the natural tendency, if you are a surgical background, is to go and cut it out and revise it. It leads to another scar. What I find the best way to deal with a linear scar that's not as favorable is transplantation. Whether I'm using beard FUE, whether I'm using FUE, or whether I'm taking a portion of the strip that I took and put in 300, 500 grafts or so to get it treated, that I find better than actually removing the scar. Now that's against the grain. But I'm going to tell you what practically works in my hands and what I've seen. Remember I told you I don't like micro punches up here? I don't. But for scars back here, I find there's no real damage to it, and it's better to use a micro punch. I use a 1 millimeter sharp manual punch to take out the scar, and then I transplant into that. Okay, so just I like to take a little scar. I don't find to have vascular issues by doing that. Anyway, so this is, now what if you have a depleted center? I mentioned this to you guys. Don't have a low threshold to take bitemporal harvest. But I told you, this is a very dangerous area if you don't know the anatomy. The distance to that deep, beautiful structures is very marginal. Here you have a little bit of cushion in some patients. The older you get, that subcutaneous flat goes away, and that layer goes away. So and then also, where's the highest tension? It's vertically above the mastoid. This drawing is showing a little bit more medial, but it's basically, this area is the highest tension. So sometimes, this is what Bino mentioned, is just leave a little gap and just harvest little strips. That's another option. You don't have to take one continuous strip. Now this is a super advanced topic. I will take sometimes asymmetric harvest with wider and thinner, stopping areas, go all this. This is a setup for total disaster if you're doing this. Okay, so I'm just showing you this is the most advanced topic. Don't do this when you're starting. You won't have the judgment or the eye to do this. Just do a standard harvest. But I'm just showing you things that what I do, and understand what this is. And it's all in the book, unfortunately. But I think I really put like 3 warnings in that chapter to tell you please mature into this concept. So these are just some examples of managing scar. These are FU grafts into a linear scar. This is scalp micropigmentation to a scar. And so I mentioned already, if I have a scar, I rather transplant into it than do a scar revision because I think it yields better. Definitely, do not do a geometric broken line. I do geometric broken lines all the time on faces. Do not do a W-plasty. There's a temptation, especially if you're a surgeon. You know what all this means. You're not a surgeon. You know what the heck I'm talking about. Do not get tempted to do a scar revision. It will lead to more problems. You're going to have massive transection of follicles, increased tension on a wound that's already not healing well. You will have either a worse outcome or no benefit. I repeat, you'll either get a worse outcome or no benefit, not improvement. So the trick with a scar that is not as favorable, to me, in my opinion, it's either a transplant into it using FUE or strip somewhere else, or a scalp micropigmentation, or both. And I always counsel a patient that it may take both because scars may not hold the grafts perfectly, so sometimes they need both. And if you don't counsel them, I always say the difference between an education and excuse, and education is told before, excuses afterwards, right? So you want to tell them, look, I don't know how much take it's going to be. We may have to do some scalp micropigmentation. We may have to do a second session. But I always say that. The patients at 1 year may want a little bit more, so I always mention that in the beginning.
Why do you use a punch for within the scar as opposed to a standard site?
So it reduces the amount of scar tissue, and it gives better growth. So if you think about the what's going in there, I have now reduced the millimeters of scar, and I've increased the good tissue that I'm placing in a chunkier graft. Does that make sense? Now with FUE, you don't get too much of a chunky graft. You're harvesting a 0.95 or 0.1 into a 1. So it has to match. You can't make a big site and place a tiny little FUE graft. So strip scars are inherently a little bit better for that, but you just try to fix a strip scar. So that's the tension of decision making. That's not easy. Okay.
So if you get an FUE transplant, you can make it a little bigger to match the content.
Yeah, but you have to. Well, you got to test it. So you don't want to make a lot of sites and cause an issue. If it's sinking in, it's too thin. So this is the part of the issue is harvesting a little bit bigger, probably 0.951. I usually don't go 1. Usually 0.95 still can fit into the 1 pretty well. Okay. All right. So you just heard these are different ideas of scar management. So summary is consider multiple scars in the right patient. Consider creative harvesting techniques when you are at a maturity level that you can do that. Do not start with that. Consider transplanting wider scars rather than a formal scar revision. So I have a disclosure. Again, I mentioned this only because I think it's amazing for women. This product I came up with, it works on really with hair shedding. For me, the FollowFlow is okay for men in terms of male pattern baldness, but it really helps significantly with hair shedding. And so I'm dealing with one with hair shedding. This is it. It's off the market right now, but hopefully it'll be back in the next week or two if my vendor doesn't lie to me. So anyway, so I want to talk about the difficulty with women because it's so difficult from an evaluation diagnosis standpoint all the way to medical management, surgical management. It's a much more complicated topic than for men. And I'm going to really emphasize how difficult it is to really go through. So I would like to come up with an algorithm to make it easier when you're interviewing your female patients of how to talk to them, because don't assume it's just female pattern baldness. Don't assume that it's all good. Really work. So we're talking about the history side. I like to divide it into unstable and stable. For unstable, I usually think of the word hair shedding because remember I told you AGA or androgenic alopecia or male pattern baldness is usually a thinning. But women can have more flagrant shedding and thinning. So I want to sort of understand the chronicity, the levels, the bouts of thinning and what's going on. Because if they're unstable and they're constantly shedding, they're not a surgical candidate. And they really need to be stabilized on medical therapy. So I got to find out, one of the first questions I ask is it stable or unstable and what the chronicity is. Okay? So if they're stable and it's, I've been thinning for 10 years, it's barely there, minus other derm pathologies, which would be a separate topic and part of this topic as well, then I say, look, we may go look at surgery. But if I'm hearing, no, I'm just constantly shedding and thinning, it's not good, I got to think, I'm all in medicine. Okay, so this is one way to think about it. So you really have to be a detective and a sleuth to really do some investigation. So for me, for women, it involves a little bit more involved than for men. Obviously, the history and physical is always critical for everyone. The history is a little different, as I'm alluding to, and I'm going to go into more detail with that. Physical exam is similar, but also different. And the difference is for men, I don't oftentimes get chemistries. But I think for women, most of the times, I like chemistry. I like to at least know, is there thyroid issues? Is it iron? Especially for young women, I'm thinking, is it hypermenses, where they're having low iron causing shedding? For women that look a little bit more obese, is it a thyroid issue? Are there other things? Don't forget, we're not just surgeons, we're also physicians. And there are things that are there. And I work with other doctors all the time, like a dermatologist or a biopsy or other therapy, endocrinologists. So I always say I treat the effect, not the cause. In other words, you have hair loss, I may throw some medicine to slow things down, but I don't know what's causing it. You need to go find someone else to do it. And so I use Eastern medicine, I use Western medicine, because honestly, here's the problem with medical doctors, allopathic doctors, MDs, DOs, is that if you don't have cancer, heart disease, or diabetes, we don't know what the hell to do. All right? Hair loss, your thyroid looks good. Bye. So this is why I work with functional medicines. I work with like cupping. I work with Ayurvedic things, just because there's a general concept toward health that we're lacking in allopathic medicine. And then biopsy if something looks suspicious. What does that mean? We'll see this as we go on. So the history, I already said there's shedding and thinning. I want to get a sense of this, even if there's rarely stable shedding, but if it's like I just shed a little bit, and and then you got to define what shedding is. So well, I lose 50 hairs a day. Well, that's normal. We can lose 50, 100 hairs a day, and especially we shower all the time. A lot of women don't shower all the time because we're worried about hair loss, and that's actually a wife's tale that shampooing will cause more hair loss. It doesn't, but it's something that we're going to do, and that's fine. So with shedding, what I want to look at is what inciting factors may have caused it. So if it's a shorter time period, things you look at is recent pregnancy, as you probably know, it holds things in anagen during the estrogen phase, and when it releases, you get shedding afterwards. Well, that's a transient thing. I usually don't put minoxidil. I usually don't go into all that, which we'll talk about. It's a temporary thing. I use my other techniques, the natural ways of doing things. Recent sickness, a febrile illness, COVID, significant protein malnutrition, weight loss, general anesthesia. These are things I ask. When I hear shedding and it's recent or something, I try to, do you have any of these things? Those are things I'm always asking. So the things you're seeing listed there, those are things I'm asking that could be causing it. Other things, trauma, African Americans oftentimes with traction alopecia, there's other things that are causing pulling. That usually just causes hair loss, product damage, anything that you can get on a history. You know what's interesting? You just open your language and say, hey, what do you think may have caused this? Oftentimes the women know. They'll tell you, and their intuition is not off, usually. So if you try to go too quickly and say, is it caused by this? Then they narrow their thinking. You want to sort of give them a little broad thinking and see what they have to say. And if you give them a little time, a little room, they may give you the answer. So thinning, again, I divided stable and unstable. So are there hormonal issues, PCOS, polycystic ovarian syndrome? Is there other things that are causing things? And the chronicity, if it's slow thinning, then I feel much more comfortable. And then what medical therapy would work for that? We're going to talk about that. Physical exam, I try to make it easier. Patchy versus pattern. What does this mean? So a pattern loss is going to be a few specific types of female that presents. You go, I recognize that as a female hair loss. That's sort of classic. And then patchy means this may need a biopsy, this may be something wrong. So we're going to show some examples. So this is a patchy loss where you look at this, you go, what is this? It could be alopecia areata. It could be doubtfully discoid lupus because usually it's more erythema. But if there's something off, it could be something else going on. So that's why you want to make sure that it's something off. And this one looks patterned, looks like just female frontotemporal hair loss. Does anyone know what this is? Any guess? That's exactly it. FFA, frontal fibrous alopecia. You're going to see this. This is shocking how few people know about this. If you transplant this, you're going to fail. Okay, this will not survive. You'll reactivate. You can activate the disease, and this needs to go to a dermatologist. You know how many times dermatologists miss this? It's absolutely sad. Dermatologists refer me this, just like for a transplant. They did a biopsy back in the crown. Like, what the heck? This is FFA. My staff is so good. They'll present to me when I come in for a Dr. Lamb. This is a 43-year-old, looks like FFA for about 5 to 10 years. I walk, I go, you're right. How did the dermatologist with an MD not recognize this? I was in London. I was 20 feet away from this woman, FFA. I walk from back there. I can see FFA across the room. So what is FFA? We're going to have a lecture on that. But the summary, so you have some redundancy here. Essentially, it's a glistening look to the front. There's this, almost you can see veins come out. They usually lose their eyebrows first. They have this telangiectasia. The whole area looks thin and shiny. When you see it, you can't unsee it. I'll show you some more examples. Please don't miss this, okay? Please don't miss this. And again, don't worry, we're going to have a different lecture on this. I just want to introduce this concept to scare you, all right? So patchy, what is this? Anyone have an idea? What do you think? I put patchy so that you know it's not pattern hair loss. Any guesses? What? Okay, any other guesses? That's it. It's CCCA, central centrifugal cicatricial alopecia, mouthful, very common in African Americans. We'll talk about the pathology, we'll talk about the diagnosis. These two things, FFA, CCCA, you need to know this. If you're not a dermatologist and you don't know these two, you're going to miss the boat. These are things that right now may look like, wow, that looks like alopecia areata. It looks like, I'm not a dermatologist. You will get this down. And I'm going to tell you some tools to get there. It's one of our later lectures, so don't get nervous. But if you are nervous, that means you care. So these two things, you should not miss this diagnosis, okay? This should be screaming at you, CCCA, and by the time we're done today or before you start your practice in hair, they need to be screaming at you. Like you walk in the door, go, that's CCCA. My staff, I send it to dermatologists. Now, if I'm going to transplant, so I have low threshold, high threshold, medium threshold. High threshold, they're going to dermatologist, get biopsy. Medium threshold, they're going to dermatologist if it's wrong. If it's right, it has to be biopsy correctly. If it's biopsy incorrectly, you can still be wrong. If it's medium threshold, I'll say I may transplant you, and you need to get a biopsy. If it's low threshold where I think it really is not, I'm going to say, you know what, I could be wrong. This could be a scarring hair loss. I would tell you about 90% certain it's not, but I don't want to do a transplant. It doesn't grow because I'm wrong. But I've done this a long time. I tell you it's very, very low threshold. If you want to get a biopsy, here's what I recommend is get a biopsy, and then we're all comfortable. So that's how I work with CCCA. But I've done this long enough that I've missed it once, and it's devastating when you miss it once because the hairs don't grow. Okay, I may have missed it twice, who knows? But it's just that's what happens. And then this is what is this actually? Any ideas? Sorry guys, this is brutal asking this question. So look at the scalp. There's a loss of ostia. It looks shiny. It's scarred. This is most. I think I don't remember anymore. This is probably a lichen planopolaris. But when you see this shiny scarred look, you start to see it. You start to think something is not right. Okay, and you'll start to get the eye to see it. Even if you're not a dermatologist, you'll get it. Now let's talk about pattern. So pattern classically is going to be, as I talked about in the first lecture, a Ludwig pattern, which basically means mild, moderate, severe in terms of thinning, with or without the hairline. A variation of this, and it really isn't a variation. It's really Elise Olson came up with the idea that if you part, it's great to take females photos of the hair part of the middle because it shows you this and it allows you to have reproducible photographs when you're because women part this way, and the photographs are all not consistent. But when you part in the middle, you'll see what's called a Christmas tree pattern. Essentially, it's a variation of this. It just means that they have more hair loss on the bottom and less on the back, and it sort of tapers up like a Christmas tree when they're looking down. Okay, with or without preservation of the hairline. And that's irrelevant only in the sense that it's just a variation women have, whether they preserve the hairline or not. And then this is the second pattern. So you got this Ludwig pattern and you got male pattern baldness. I'm not talking about congenital high hairlines that we want it lowered. I'm just talking about female hair loss in general, minus like traction alopecia, other things. General pattern females. The easiest way to categorize it in your mind to make this not complicated is you've got density issues, which are sort of Ludwig type problems, and you've got male pattern alopecia coming back, and sometimes you have both. Okay, if you think of that way, I make it easier. I can make this very complicated, but to me that's an easy way when you're writing your notes, looking at a patient, and of course that means you've ruled out patchy. Okay. So chemistry, what are they? Basically, it's a full blood panel. It's looking at thyroid function tests, looking at because women have a higher incidence of autoimmune, looking at this ANA, is there lupus or anything like that. 10% of discoid lupus has systemic lupus erythematosus. Iron levels, especially as I said, women that have menses to look at if that iron level is causing that issues, PCOS, other hormone issues, postmenopausal, their estrogens are out of whack. Does that mean they need HRT, hormone replacement? Maybe not. It's not your deal. But if you point out, hey, your hormones are way out of whack, they may be able to work with someone to do it, or they may not decide to do that, but at least you give them options, because otherwise you're thinking, we just need to transplant. But if their estrogen's off, it's a good thing. And the number one male hormone in a female is something called DHEAS, or dihydroepiandrosterone sulfate. So that's a classic one to check, estrogen. All these different ones are critical, so that's very important. So to summary, to make it very easy, I like algorithms. They're easy, so your brain doesn't get lost. When I walk into a consult, I think unstable, stable, patch your pattern. And then if it's stable and pattern, I have a low threshold to consider surgery if the donor is good. And if they're patchy or unstable, I'm looking either a biopsy with a dermatologist, or I'm thinking, okay, maybe I need to go do some medical therapy and work with other people. Always work with other people. When I was president of the American Board of Hair Restoration 32 years ago, and when someone comes in with a lot of bravado and says, yeah, I'm going to just transplant, if they don't know, and I make a biopsy, I may get with a dermatologist, I have a much higher tendency to pass that person, the guy going, 2,000 reps, and it's a CCCA. Okay, I mean, at least if you don't know it's CCCA, just go, I don't know what this is, it doesn't look right. That's your caution is critical. Patient safety is so important. So management here is going to be breaking it down, as I heard from the first lecture, between chemical and natural. Okay, and I will tell you that with women, I get pretty good results with natural. I don't often. It's interesting. It's against the grain. My first line is natural for women. I oftentimes do really well with this variation of the PRPs and Caravive with my Foliflow. Again, I'm very sorry that that's a disclosure, but I'm going to tell you I'm doing it because the product is very, very good. It works well. I can't do this on podium, but I'm going to tell you this because it really does work. So these are the products that I'm passionate about. And if they fail natural, I do biochemical. But if something goes, Doc, look, I like minoxidil. I want that. I don't believe in all this natural stuff. Okay, good. Let's do this. And so for me, a really good test, that trickle test, gives me some way to just, if they're open to doing that test, it gives me a little bit of diagnosis so that I can go, oh, you know what? If you're open to oral minoxidil or postmenopausal, like I just had a lady last week, they said 3 milligrams finasteride and I think 2 milligrams of minoxidil. 3 milligrams finasteride, they didn't make that right. But this diagnosis tells me this is what they need, or they need to be on 0.3% dutasteride topical with a glucocorticoid. It gives me a little bit more flexibility than a standard dose. But for those that don't want it, it's fine. I will do a standard. I will assume that there's an inflammatory component. I'll use maybe a light glucocorticoid with minoxidil topical. If they want to go that way, or I'll start at a 2.5 milligram minoxidil. So these are the way that this is how my brain thinks. Does that make sense? So summary again is I usually start with the natural, and if that doesn't work, I go to biochemical. If they really want biochemical, I would prefer the trickle test for an ability to finesse the treatment. If not, I will just go with a standard oral or topical, whatever they're open to. Of course, as you know, finasteride is a teratogenic, so I'm not doing it in women of premenopausal. Do you have a question?
I do.
Yeah.
Women that are more getting testosterone treatment.
Yes. I see, right.
Right. And if they're experiencing hair loss,
Yeah.
is it more of a male pattern DHT issue?
That's a good question. I don't know the pattern of how that. I haven't seen enough of those to really understand. But as you know, if there's something that you can on the chronicity level see that it sort of was exacerbated by hormones, you got to look at that history and make a decision. What's worth it to change, or not. So, but I can't tell you with certainty. This is a lady that did not do well with standard minoxidil, and I gave her a compounded one with a little bit of light glucocorticoid. This is before I was doing the test, and she got a better result with it. So the other thing that's important, and this is so critical, when I'm doing a consultation for a female, I always mention this if I'm going to surgery, is they're not may have shock loss. I say you're going to have shock loss at some level. This is the single most important thing you communicate during a consultation if you're contemplating surgery on a female, that they can and will have some level of shock loss. Shock loss is that temporary telogen effluvium, and I say you may need wigs, you may need scarves, you may need something to cover it. It occurs a few weeks, a few months later, and then it does come back, but it may be devastating. I use those words so women are prepared for it because women shock or shed at some level. How do you mitigate it? If they're doing long-term minoxidil, start as soon as you can. If they are not wanting minoxidil, I do 6 weeks minoxidil before. It really helps minimizing shedding, and I always mention that minoxidil itself can cause shedding, and don't stop because of it. 5% once a day is what I do, topical. I have a bias and think that even if they're on oral, I like the topical, and the topical itself has a little bit more protection on the shock. And my staff are trained to, during the pre-op, say, hey, are you on 6 weeks of minoxidil? Everyone. Because if they're not on it, there's more risk for shock, even for men. But for women in particular, it's more important. And the education, remember what I said, the difference between education and excuse, and education is told before, and excuse is afterwards. So I always like education. I'm not a big fan of excuses. So I also reduce the epinephrine. So what is your reduction? It's in your notes. You have what epinephrine I use for women and the cardiac. It's the same. It's a little lower dose. It's all in your notes. I may be a little less aggressive with the tumescence. I'm a little less aggressive with dense packing just to minimize shock loss. I'm very cognizant of being not so close to a miniaturized hair. All these things are important. Then afterwards, I already give you a mention of these. These are the things that I do. I tell them, for example, with women, you're going to see this. If I do a, if they're a part, you're going to see this in a moment. If I'm doing a left part and a center part, that means their right side is probably okay. Then they have to comb it this way. Okay, so they have to comb it in a way to cover their shedding. Does that make sense? And I tell them that at the time of consultation. I tell them that at the pre-op visit. I tell them that on the first day afterwards. I tell them 3 to 4 times. If they don't remember, it's not on me anymore. I've already told them verbally multiple times that this can happen. And that way they're prepared. If you're prepared, you know it's temporary. You don't get as angry at me. All right, every day I'm dodging bullets if someone's getting pissed off at me. I'll be honest with you. So that's what I'm trying to do is not have anyone upset at me. So. Anyway, so the other thing too is you got to be very careful with hair fibers. You want to start no sooner than 2 weeks, and if you go crazy with it, you can kill off the follicles. So they've showed studies of that. So just be very light on the fibers, no earlier than 2 weeks. This is one of my most devastating shock losses. Look at that. She has an amazing result. She's actually used on my before and afters, but that's a donor effluvium, and that is a effluvium on the front scalp too. That is devastating. That can occur, and it's important people know that. This is just showing you the indications for female hair transplant minus traction. It's basically, well, you could include that in the lowering. So I would say general hair loss of some kind, either frontotemporal loss or Ludwig, and then some kind of hair, lowering, whether it's from traction alopecia, hairline lowering, or frontotemporal recession. So those are my 2 things. I usually divide into female hairlines and female density. Okay, and I told you already, I try to avoid harvesting out here if they have poor donor. But if they've got decent, I'm going to still go temporal and take it because I want to take as many grafts as I can, especially if they're overall poor. So don't just not go to the temple. But in general, you're not going to get a lot from the temple. Oftentimes, not always. Of course, with congenital, they just have a high hairline. They're going to have great temples. Design the hairline. So you're going to start with the macro hairline and the micro hairline, making some finesse works, and really look at the flow of natural hairlines. They are much more complicated than men. Okay. And just look at, these are my staff members. You can take a look at, this is an oval with a little bit of a cowlick and with a little bit of a widow's peak. It's a very pronounced widow's peak, more of a rectangle. This is a little less pronounced widow's peak, but it's very, very rectangular. So these are different shapes. Look at female hairlines and try to design one that works for them.
We have things and everything 30 degrees anterior, right?
They actually go backwards sometimes. So it's very complicated. You saw those, they look like this, right? Yeah. So I follow either native hair or I will design it backwards. Most female hairlines I design are actually all over the place, and that's why it's so hard. You saw a little bit of it, and that was recorded yesterday, so you can review that if you want. It's also in the book. I actually show that in multiple recipient side designs in the book. So Ludwig scale, just to repeat again, may or may not spare the hairline. You can look for the Christmas tree if you like, but this is a really good simplified design algorithm because women, their density is not good in the back, so you've got to cheat. The take-home lesson is don't treat it like a male design. Women don't go completely bald. That's good. So you don't worry about just transplanting one side. Whereas male, if they go bald, you have this little patch over here that looks crazy, and they don't wear their hair long. So with women, their donor's not as good as men oftentimes, but they wear their hair long, they don't go completely bald. So you got to leverage those problems and benefits, which means I do what I call a T, L, or dumbbell. So what does that mean? So the L is basically the left part, reverse L would be the part on the right, and the T would be the part in the middle. So I look at the hair part, I look at the central forelock. Those are the T's and L's. Those are critical zones. And then the dumbbell is just a thing I came up with ideas. I remember I mentioned briefly the crown, but we can hear more in my crown lecture, that hairs go up and out like this. So they lose that volume back here. Oftentimes you don't need more than a few hundred grafts to hit it, just in the center, just to create a little lift. And you got to undersell that, but that's what I call a dumbbell, a small circle in the back, just to create a little bit of lift. This is, you already saw this design, which is the idea that most of it is distributed either in this center part or one side or the other, and the vast majority are going to be just mixed grafts going across that area. Sometimes I may spare out a number of 3 hairs to hit the central zone if I want to get a little bit more density in that area. In terms of the differences, you asked this question, Billy, and you see the male hairline go straight forward. Look at this female hairline design. It goes off to this side, goes off to this side, goes down like this. Male hairline again, straight forward. Okay, female hairlines curve all over the place. All right, so that's the tricky part. This is the dumbbell design. On the left, you see the front. On the back, you see the back circle. This is just showing you what I talked about. So how do we break down recipient side? You asked about this. These gorgeous illustrations from Mason from the book. And so you see, I first draw the line. I come back and I draw the micro hairline. Sometimes there's a little bit of a widow's peak in the middle. These lateral mounds are just a little bit of lateral protuberances. I don't always draw them, but you can, if you look at women, you oftentimes see these little lateral mounds. I then draw in, as you saw in the lab yesterday, the proposed flow of the arrows. That way it tells me how to make those sites. I start with the hairline, making some 1-hair sites that would match the micro hairline in the direction of those arrows or those lines. And then I build up some 2-hair sites behind that. And once I've done that, I come back and I make my sentinel sites in front, usually in a perpendicular fashion, so my staff can easily read that. And then I do my blending of my 2s and 3s going back. Okay? And this is in the textbook, and this is in your thumb drive, so you have that. And in the video, of course, you'll get that as well. Yes, always, always. You always want to put sentinels in. The only exception would be someone 60 years old. They have a bucket of sentinels in front. I don't waste it. I just go behind because he's not going to lose it. I can build behind it. But if I have to build a new hairline on a 60-year-old, I'm just going to put sentinels in. They should have it. You should have naturally have sentinels. So this is just a congenital high hairline I did with a transplant. I don't really like advancements because you miss half the battle, which is the temple. The hairline advancement only goes here. You miss all the temple. And part of the joy is the temple design. And this is a frontal temporal recession. This is a lady that was on a lot of steroids as a bodybuilder that I had to rebuild. And this is the frontal temporal recession I built on a Asian. This is just showing you I did a little scalp augmentation and a little bit of frontal temporal density as well as frontal transplant. This is traction alopecia. Apparently she's not as happy afterwards. I don't know. Just inconsistent photograph. This is a MTF transgender hairline. Took me 2 sessions to get this low enough. This is a bad tattoo that was transplanted. This is a Ludwig 3 made into a Ludwig 1-2. This is a Ludwig 2 made into a hopefully non-Ludwig. This is a Christmas tree that's made a little bit less Christmas tree. So the summary here is look for stable versus unstable, look for patchy versus pattern, consider natural therapy, that's my bias, counsel and lessen shock loss from the very first consultation forward. Sort of divide your design patterns into considering hairline versus density. When you're looking at hairline, think about the cow wick, the rotation, the shape. Density, think of the TL, reverse L, and dumbbell designs. How do you present something that you can't really see? You have to present all sides. Because, as I told you earlier, it also helps the roundness on the side. It's not just the back view, if you do it right. And it also helps the frontal visual density. How does that work? Because the upper arc of the crown covers the hair part, covers the front. And I'm going to talk to you about some creative designs. That creativity is going to be very sophisticated, and you're not going to capture all this understanding. You're going to get a nice preview of how creative this can be. So who's a candidate? To me, you have to have someone old enough. If you heard 35 years, you go, well, this guy's 36, done. You know how many 36 years old I turn away from a crown? A lot. I'm just saying don't do someone young because you have no predictive capacity on that. I want them stable in medical therapy. I want them to have no side effects on medical therapy. I want them to really believe that they're doing it, they're compliant. I really prioritize the front over the back because if I try to do it back, it doesn't look natural and it's expanding. I'm trying to fight a mess and the front looks totally horrific. Remember I told you about the comb back. It's a great technique to cover the crown, especially when I feel it's unsafe to do the crown. And then they get a full head of hair. You know, I was at a conference recently, I looked at a colleague of mine, I go, oh man, he's totally bald this crown. I never even noticed that because he combed it all back. You know, I just saw a little sliver of baldness there. In fact, I had a patient come in from Seattle that I did a transplant on, and he was, I forgot why he was there 2 years. I had no hair loss. I realized he had combed it all over his crown. He had a big crown that I just needed to correct the second time. But that's why the crown is not as important and riskier. And as I said, you really want to make sure that that crown is stabilized. Don't just day one here, see a crown, go, you know what, I'm going to do a transplant. And then really, this is the key. Remember that supply-demand curve? It's heightened in the crown exponentially because if the front fails, usually because it goes to a Norwood 7, this drops away. Not many men go to a 7. Not many men drop their lateral humps, but a lot of men, the crown expands. So and you know how many grafts it takes to build a hump? Usually not a lot. Usually not a lot. You know how much it takes to build a crown? What do I remember? Pi r squared. Nightmare. The crown is not difficult surgically. It is a little bit. It is a little bit, but it's difficult judgment. Okay? You've heard me say things 5, 6 times when they're important, and you really need to understand that. You have to tell the patient they're going to need more surgeries. Okay? I didn't need to know that. The doctor never told me that. The crown expands. I hate to say this. All right? You got an older 6-year-old, white hair, fine. You got a 30-year-old with a big crown, disaster. Okay? Blazon this into your brain. This is the number one thing I start with in your textbook, okay? And that's the thing I want you to first walk in a consult. I look at supply and demand. I make a judgment right then and there. Can they do surgery? Can they not? Should they do surgery or not? Can I do surgery? It's the first thing I look at, and it guides my whole consultation. Pi r squared, pi r squared, pi r squared. All right, this is a geometry lesson that you need to know. Double the radius, quadruple the burden. 3 times the radius, 9 times the problem, okay? So this is critical. These are the problems with the crown. Large surface pi r squared issues, prioritizing the front over the crown. Billboard effect, basically what that means is if this is the crown, I'm looking at spot on. What is the problem with the crown? What is definition of baldness? It's not just the absence of hair, it's looking at scalp. When I look at the top of the scalp, I see it like this. When I look at the crown, I see it like this. It's hard to cover that. And these crowns, hairs don't shingle. They whirl over each other, and they're always splayed open, especially if the whirl is in the middle. And lower graft survival. Unfortunately, the crown has a little lower graft survival in the front. Okay, so these are the 5 reasons why crowns are a pain in the butt. All right, do I love crowns? Sure, but I also hate crowns, and this is the reason why. So crown hair loss shapes, they all come different sizes. The one I want you to know, the cornet. We mentioned that earlier. See that little circle on the far right? Look for it. That means your donor is compromised. That means you have to go lower. You have to transplant more and take less and be worried about future problems. Look for the cornet, that little area. Ziering talked about different patterns. Why do you need to know this? You don't, but it's good to know. These are the patterns you found. Okay, they're different clockwise, counterclockwise, double whorls, diffusion patterns. Women are more likely to have diffusion patterns. Planning the donor. What as I said, look for the cornet. Got to stay away from it. So with the strip procedure, as I told you, I prefer this when I'm doing crowns because I'm far enough away from it. However, remember what I told you too. If the crown is way up high and I've got the sexy hair way down toward the nape of the neck, I may do FUE because I can pull more from there than I can with a strip. Very advanced thought. So I don't always do strip. But when I see the crown, I always lean toward strip for the reason I said. So initial plan, you draw it out. And then when you wet the hair, you notice, you know what? Oh my God, there's more zones of mineralization I didn't hit. You better hit those because they're going to be a problem within 5 years. Older patient, I can stay with that design. Younger patients, I'm worried about progression. I may go a little bit beyond where I see to minimize that risk. So I have to step off in a few years. Female crowns, I already mentioned this to you. I look at a dumbbell design. And then just in terms of anatomy, just a lingo that I use, I have the vertex transition zone, which is that transition from vertical to horizontal plane to the posterior mid-scalp. The center of the world, remember I told you we start with the design there. There's an upper arc and a lower arc. Anything above the center of the world is upper and below is lower. The other thing that you heard is there are no abrupt transitions. So when you bend in a clockwise fashion and you join the surrounding hairs, you need a gentle inflection point that goes up. There's no, okay, everything is flowing. You need to think about that. So what are some preferred designs? And this is part of if their perimeter matches your design, which is important, let's look at where they part their hair. Let's look at where, if they have no hairs left and you have a clean palette, that's great. If they've got hairs like 30% hair, don't design some whorl that doesn't match what they have. It'll look ridiculous. But if they're blank slate, now you've got some options. Do I put a whorl in there? Do I put it on the top, bottom, middle? What would be the most effective? Remember, you're struggling with a crown to get good density. So now you have creative options. So this is what you do. Here's a trick. I'm going to give you some concepts and we'll put it together. If you put it up high, the gravity lets the hairs fall down on it and covers a lot. You put it low, it's got to go reach up and hopefully not splay open. So ideally it's high, right? Second concept, if the hair part is the worst zone, people see exposure, which if you can put those grafts going up over the part, that would be nice too. Does that make sense? Remember I told you that third part of the picture is the front. And so if I can put my whorl going over to the hair part, it would be cool. If they follow the same direction as opposed to, if they part their and comb their hair this way, it would be nice if it didn't have to compete against that front. Those are my thought processes. So you see those 3 colors there. The blue is it matches the hair part zone. The yellow means it matches the mid-scalp hair. And the red shows that it sort of does a cascade effect. Hey, remember that talk from yesterday? This is how I leverage cascade. So it covers over. So I put a little bit more density up high. But remember, that doesn't mean you put a bucket up here and nothing down here. It will look bizarre. The cascade is one of the most dangerous things for a beginner. All right, I'd rather you forget it for a moment. But still, even though you may create the same density, you understand that just by putting your whorl top left, if they part left or right, that you already get the cascade without having to design higher density in zones. Okay, but to be fancy, we talk about advanced topics here too, which is if we're going to prioritize slightly larger grafts, slightly higher density gradients, look at how powerful 1 is. 1 goes all the way over and covers the crown. 2 covers the crown pretty well, so that's priority 2. 3 covers the hair part in the mid-scalp a little bit, so that's priority 3. And 4 doesn't do too much. Does that make sense? So that means you could make some density gradients. But again, I want you to forget the slide. This is an advanced topic. It's just for you to see the creativity. But if you start doing this and putting a huge density in 1 and forgetting 2, 3, and 4, you're going to mess up the patient. It's more for creative thinking. This is showing you density priorities. What if we have a different place? What if they have a whorl that starts down here and you're stuck with going low? Well, now 1 is arching up over that whole area because now the whorl is low, so I need to come up and cover the crown. It's no longer high, and it's going clockwise, so it's covering this way. 2 is covering most of the crown, 3 is covering less crown, 4 is covering almost no crown. So I would put more density in the 1, 2s then 3s and 4s. Does that make sense? This is just creativity. I'm teaching creativity, not I don't want you to go and do this exactly, okay? This is showing you a third design. This is a counterclockwise lower whirl. Then now that one is over to the right because that arches up this way. Does that make sense? All I'm teaching is creativity. Don't get bogged down with these details. They're not relevant to you at the first year of practice, okay? All right, so then density by graph size. We most times don't have 4-hair graphs. They're mainly 2s and 3s. But if I can put a few more 3s to the center of that whirl where things play open, but not right at the center, then I can put some 3s over zones that have some better cascade. I'll tell my staff, if you got some decent 3s, let's segregate them a little bit, let's put them a little bit over here. But to be honest with you, again, I would just evenly space everything. I'm just trying to teach you. The easiest thing to teach you is if you've got it, out of all these crazy fancy slides, the only one I want you to remember is if you've got a blank slate, think about designing it based on the priorities of direction of mid-scalp, hair part, and gravitational fall. That's the only slide that is relevant to a beginner. Does that make sense? The rest is creative nonsense meant for you to mature into the thinking to show you how cool this is. So that you can go, man, that's my 5-year goal. I'm going to start creating density gradients. Not yet. Please don't start doing that. You're going to mess it up. So how do you do this? These gorgeous drawings by Mason. I love these. So you first draw out your perimeter and your wheels. Why draw the perimeter out? Does someone remember from yesterday? Read my mind, no? Here's the answer. Because if you don't draw the bottom portion, you may miss how low it goes because your headrest is going to block it. And then draw the spiral spokes so you can follow it. And always start in the center. You heard me say that. And then go out from the center in design. Okay? I like only parallel sites. I've done coronal sites for perpendicular sites. Nightmare to try to find these things. So, and I use solid chords, you know. So these are basically to show you some design patterns. And remember, why do I go high angle in the back? It's natural. It's the way hairs naturally grow. I can make a tighter placement. Remember the subcutaneous competition I mentioned? And it provides more visual lift and roundness in that area. And this is just showing a schematic of that. I already mentioned this to you. When I'm doing hairlines, I have the patient in a supine position. When I'm doing crown, I'm either standing where the patient is least upright. When I'm trying to get those lower angles, I either have them in a decubitus of one way or the other to make it easier in my hand. This is just showing some examples, a clockwise whirl, and then you can see the roundness that I'm talking about. That it just you can see the baldness from the side view. People don't think about that, but look, you can see that he's balding, all right? But it's so much thicker from the side view. This is a slot deformity. This is basically from the scalp reduction. So what the heck is a slot deformity? We have a lecture on that, don't worry. These are a weird pattern that's there. That's just from finasteride retaining what's left. This is a diffusion pattern I did for a female. Even finer graphs place really, really well. It makes it look better. This is an upper arc. In other words, most of all the graphs go up, and that's great. When all the angles go one direction, it no longer becomes a whirl problem, right? And then you get better density on that result. Does that make sense? I love that. This is and you know what's great about plugs? Almost nothing, except if you can cover them, they provide so much density. Okay, so much density. Don't take them out. All right, if they're in an area that's not exposed, like the hairline, even if you can lower the hairline and put grafts in front of plugs, don't take them out. Those plugs will give you insane density. The only time you got to take a plug out of it is not where it should be. That's a little pro for you. Okay, I didn't take those plugs out. I just put more grafts in. Those plugs disappear from your mind. All right, can't see them anymore. They get so much density so fast. PRP therapies, PRV for someone that was on stable medical therapy, did a transplant many years ago, had a little loss, it just built that up. And so the summary here is choose a safe patient, supply and demand curve, blazing out your brain, explain limitations here, look for that coronet, and plan creatively. But remember, the only creative slide I want you to remember is where to position it on a naked scalp, and nothing else about density gradients. All those things are going to be problematic. I don't want to see over there you're trying to create a higher density here and lower density there. If you're only a year or two in practice, I'm going to have a heart attack out there. I won't finish the course. Okay.
You decided to do PRP versus
I don't do PRP.
transplant. You know,
Oh.
the kid with the PRP.
Yeah, I don't do a lot of PRP anymore. I really do the Caravive nowadays. So really for me, what I'm doing, really honestly, is that if they're, remember what I said, if they're bald, they need surgery if they're safe. If they're miniaturized, they need medical therapy over surgery, with one exception. The exception is a 65-year-old. They're miniaturized. They don't want to take medical therapy. Too lazy. And they've got insane donor capacity. Fine. We'll do a transplant. No problem. It'll last you hopefully 10 years and you don't take the damn thing every day. 30-year-old, crowned, miniaturized, scared out of my mind to do that with a transplant, is going to be all medical therapy all day. 45-year-old, probably medical therapy plus surgery. The older you get, the more surgery, less medical therapy. The younger you are, the more medical therapy, less surgery. The more miniaturized, more medical therapy, less surgery. The balder, more surgery, less medicine. Does that spectrum make sense? Okay, so just starting with Jeff again, he is a Norwood, he's really a 4. I mean, there's enough loss here with miniaturization, with crown expansion, this is a 4. It can be a 3, but I would really say it's a 4. What you're noticing in terms of miniaturization is all the way through his scalp into this mid-scalp. You can see that his crown really ends here. Does he have a coronet beyond that? Not really, it's sort of a rounded area. So this density looks pretty good here, but it's very close to this area. If you look behind, he's got sort of miniaturization coming up on the retrograde side. You can see it when we were looking before off this area here. You can see that area. This is a zone that's a little bit risky. You can see that here. On the other side, let's take a look if it's symmetric. Yes, you may be a little bit better dense, but in general, there's retrograde loss here. This is a dangerous zone. If you look carefully, you can see the miniaturization wave going down here. You can almost see it coming encroaching all layers. So there's a lot of risk here for both FUE and strip. Okay, so he's got a very limited donor capacity in the central zone. Starting with sort of the palpation, if I sort of feel, if you guys don't understand how to feel, if you don't mind getting massaged by some students, this is the superior, this is the bony occipital protuberance, and that ridge there's our superior occipital line. Does anyone even feel that or no? Okay, so the first bone, that the lump is the protuberance, and the bottom edge of it is the superior nuchal line. Sorry. Okay, and this is the inferior nuchal line. Hold on, let me feel this again. This bump here is the inferior nuchal line. Feel this bump, depression, and second bump.
So that's the depression is the
No.
superior ridge.
Yeah, the ridge is right below it. So bump and the ridge with the shelf under the superior nuchal line. This is the inferior nuchal line. Okay, you feel it? Right? You feel it?
Yep.
Okay, actually everyone feel it. I think this is important. Feel that? That bump and that you're right on it. That's the bump, right, it's the protuberance with the edge below the superior nuchal line. And then do you feel the inferior nuchal line? Right about there. Yeah, that's the last one. Now you're into
Superior nuchal is here.
That's right. It's right underneath the bump. The bump and the line are the same thing. The bump is the top part of the line. Okay. Where the shelf goes in is the line. Okay. So laxity, he's very lax. You can almost see it, right? Now let's down here. You see there's a little tightness? Now this is the mastoid right here. Does anyone even feel the mastoid? No. Okay. So it's tight. Okay. It's tight. Loose, loose, very loose. So why am I feeling this way? And this is another way to do it, but I don't care because I'm not closing the wound this way. And I'm closing it this way. So there's a lot of discussion of going side to side, back and forth. I go up and down. One trick I didn't mention in these lectures has so much information. If they have a previous scar, and I'm checking for, it's tight, and I'm like, oh, I gotta do a second round in a year, 2 months. I start doing scalp relaxation exercises. Have you heard of that? So essentially what you're doing, you're clasping it, putting it behind, you're feeling the mastoid prominence or above it, and you're just doing your figure of 8s, side to side, up and down, maybe 5 minutes, 3 times a day for however many weeks they can, whenever they think about it. And that will help loosen that a little bit. It's not a huge difference, but it's breaking up some scar tissue, it's making it relax a little bit. Okay, so anyways, now that we know the bony landmark, so where am I going, if I were gonna harvest off him, this to this is pretty good. But man, that's narrow. So FUE, for me, no way. Okay, strip, probably still risky. Okay, I need him to be on medical therapy for, make sure he's stable, etc. But there's a very, look at this. If that comes down, we're in danger. If that comes up, we're in danger. Scars exposed, and then he doesn't have anything over here. So my limit is this, and that's a very narrow band where my margin for future is risky. Let's propose he were 30 years old. No way in hell. 40, most likely not. 50, maybe. 60, possibly yes. 70, yes. Okay, now so I just changed his anatomy and put an age on him. Does that make sense? Okay, thank you. Yeah, let's take Alex. Okay, so let's take a look here. We'll do the front. So let's ask you guys, do you think he's not a 1 or 2, most likely not a 3. Is this a 4, 5, 6, or 7? 4, okay. Any other guesses? Everyone say 4? Yes, he's a 4. So what defines a 4 is that he still has pretty good hair here. A 5 would be, this would be almost gone, remember that? 6 is gone. So this is a 4, all right? So I'm probably for questions. I think it's important for you guys to do the thinking process of grading, not just calling out a number. So it's a 4, and he's lost all the way to the front. He's got miniaturization all the way to the top. You can see that all the way to the crown. Now, we look at the crown area. He's got a cornet, or if you could call it a cornet, it looks like this is pretty good, but it goes down like this. Is that a cornet, or is it just a low crown? I don't know. You could probably call it maybe it's a low crown. Who knows? But you can definitely see miniaturization ending somewhere about right there, right? And if you wet his hair down, you may see it actually goes down to there. Close inspection, overall, he's got a little bit of miniaturization. It's probably on the order of 15-20% on the donor, but overall, it's still favorable. He's got pretty good. Now he has much less miniaturization. How do you know that? Because I can see it for some years. But if you can't see it, look carefully. Okay, use a dermatoscope. And then we look onto the sides. Now here's great. He's got gorgeous all the way across. No compromise out to here. How old are you again?
48.
Okay, so he's a good age. I could go past the helix. His hair really does well all the way here. Now he's got maybe a little bit of miniaturization, if you will, but it's up here. Now this is a great example of a guy that I would, well, let's finish this exam. He's got good hair all the way across here. So this is a really good transplant candidate if he wanted it, okay? But because his density is favorable, he's got a huge margin for me to work with all the way down here. And I would do a strip for him. He's at an age where it's going to heal well. He's not going to wear his hair short. He doesn't have to go shave everything. I wouldn't do an FUE. It's my advice. He's got exposure risk that this is going to drop. He's got a narrower fringe. Now, is there advantage doing FUE? If you look at where his zone down here, there's a little bit of miniaturization. I don't get any gain of FUE because I can't take the good hair down here. I've had a guy recently, I think I mentioned to you, he had a wall of hair down to his nape with no retrograde and at a high crown. He was I lose that much with a strip. I said, first pass, I think FUE is probably good for him. He doesn't have that. He's got this sweet zone. It's pretty wide. He's a good age. He's got, and I would do, to minimize, what I would counsel him on is I would mitigate the risk by saying, this area here is just beginning to thin. Maybe to have the fewest transplants possible, I would hit his front and mid scout really hard and maybe consider just medical therapy for that. If he said, look, I'm close to 50-50, I really want this done, I'd be open to it. Because if we don't dense pack this, give him a little bit more. The way he combs his hair back, it's fantastic, it covers this. Everything here is leverage over his crown. And then if we look, let's look at some of the landmarks. This is the superior orbital, superior nuchal line, right here, the bony protrusion is right above it. This is the inferior line, right, inferior nuchal ridge, so here it is. As I said, I usually go on it, but look at where on it is. It's too close for my comfort. And here's a great example of someone where I go on the inferior nuchal line. The inferior one is right here, okay? He's got great hair here. Now let's look at this hair. It starts to not be so good here, and it's pretty good here all throughout. So let's get the best part of the lower portion. So I would probably go from inferior nuchal ridge. Again, that's a more advanced concept. I would rather you stay away from the inferior nuchal line. In this case, I would take inferior nuchal line upwards because this is thin. I don't want to get down in here. I don't want him to retrograde up. But I would take it here so that if he had to come back and do more, I would harvest a little higher. Does that make sense? I have a margin and the tightness, let's feel it. He's pretty good. I can get down in the inferior nuchal line, not an issue. Pretty good. I mean, again, for me, it's a vertical glidability. I don't care so much about this. You can do that, but it doesn't help me this way. It only helps or hurts me this way. Is that any questions, please? I'm going fast.
You're saying, okay, I can do a centimeter graft versus a 1.5 versus.
He can do anything.
Okay.
I can do 1.5, but I'm always cautious. Yeah, go for it. And this is the inferior right here. Feel that bump, that big bump.
I'm just trying to feel that laxity.
Yeah, he's lax. Okay. Now, is he super crazy lax? No, sometimes super crazy lax is bad, but it's lax enough in an area that should be very tight.
So would you consider an FUE?
If he,
I mean,
yeah, so
he says,
okay, that's a great
I don't
question.
mind cutting it down. I don't want Star may go shorter hair.
Okay, so he could be an FUE. He is in the gray zone. He is leaning toward strip because of his age, crown loss, but his crown's not bad, and he's got good usable hair here. So he is absolutely gray in the sense that he could be FUE. I would discourage it, but I understand if he's like, I'm an athlete. I like to shave my hair down to really close things, and I want to. Okay, then I start leaning toward FUE. But and so there's some FUE only, strip only. His is not strip only. His is not FUE only. His more toward strip for all those reasons. But if the counseling comes along that way, I do lean away. So it's a great question. I think this is a good exercise, right? Beyond just showing how to hold a scalpel, which I know you want to see too. We're going to get there. We've got plenty of time today. Okay, so insane laxity. The problem with insane laxity is that sometimes it predisposes to bad scarring if you're doing a strip, especially 22-year-old no weight hell. So of course you don't need to transplant.
Why would that be? Because seems like there's less.
Correct. So there are thought processes like they call it Ehlers-Danlos syndrome, right? Which is that it predisposes toward hypermobility and laxity in big stretches. So if you have hyperlaxity, it may not be good. Okay, if you don't know that, that's a common knowledge in the hair world. Okay.
Yeah, that's underdiagnosed a lot. Ehlers-Danlos.
It can be. And so a lot of things I say very off the cuff. I assume that knowledge. If you go, what the hell are you saying? Just ask me because I apologize. I'm assuming some knowledge, and I usually try not to do that. Anyways, so this is the superior nuchal line here. Okay, and that sits right there, and his inferior is right under it, right here. So this is the distance here, and obviously he's got maybe a little miniaturization going across here, but overall great donor. He's just super young. He's a little bit of miniaturization. You can sort of see it, right? There's a little bit of thinness across there into this area, and he's in this. But overall, if I had to do something, the younger the patient and the smaller the loss, the more likely I'm doing FUE because of high risk of scarring in a younger patient, and also more options for future issues. The more crown, the more extensive loss, the older the person, the more likely I'm going to strip. That's just a general algorithm across here. What would he be on a Norwood scale? Any other comments? So you got a 1, a 2. We're saying 2, or what are you saying?
Let's go with the 2.
So we got a 2. Let's take a look. I would say this is close to a 1. I mean, it's a 1-2. I mean, there's a little, but this is close to a 1. I mean, it's almost 90 degrees, but you're right. I mean, there's a little risk. Okay, so 1-2, whatever. That's somewhere around 1-2. Thank you. How old are you, Rico?
32.
Okay. See, I haven't really asked about that. I'm just doing an evaluation today. So if we look here for him, first of all, what's his grade? 1, 2, 3, 4, 5, 6, 7.
The crown.
1, 2. Sorry.
Probably 1, 2.
Okay, so you say a 2. So we have, okay, who's a 1? Raise your hand. You got a 1?
I'm in between 1, 2.
Okay.
I'm like between 2, 3. We're all over 1, 2, 3.
You want the answer?
Yeah.
3.
Really?
So let me explain to you why. That's right. When there's miniaturization a little bit in the crown, you immediately go to a 3. Okay. You can even have no hairline loss, and you have a little thinning. It's immediately a 3. So he doesn't really have a lot of recession. So I get the trick. I understand this because if you look at this would definitely not be a 1. It would be at least a 2, but it would be a 2, maybe 2, 3. You could argue say 2, 3. I usually write that because it doesn't really matter too much. 2, 3. It's just a lingo that you can document things and have your brain have structure to it. But in this case, 2, 3. I would say 3. I think 3 is. If you argued it's only a 2 or only a 3, it definitely would be in a 3. It would not be a 2. Does that make sense? So he's got some Yeah, exactly. A little bit of miniaturization, and I would be very hesitant. This is almost some dupa, some thinness across here, and that's the thing is that, and you can see a little bit of retrograde refinement across here. This would be a great example of a patient, I'm sorry to say, I wouldn't operate on. First, he's young. Second of all, he's got a lot of diffuse miniaturization across this area. I think this is a problem in the future. I would get him on medical therapy. If you're not on medical therapy, find someone local here. There are a lot of good surgeons nearby. I can refer to someone here. But medical therapy would be good to protect all of this because he's still very early. It's a great time to do something protective. But this is a great example of an early dupa where you would just be very cautious to go in. You would just be cautious to do either FUE or strip on it. And the graphs, if you look, they're very, very fine. There's a huge percentage of miniaturization. I'd say probably on the order of 30% in this area. So this is something. And if you don't have a question, I'm sorry, we don't have your for this course, but go on magnification. If you don't have anything, take an iPhone, take a close-up photo, and blow it up. So these are some ideas. Good? Okay. Right. That is it. Let's do now, transition over to do the harvest. So this is a multi-blade. This is what the old days people did. This is how they harvested everything. That's how I harvested everything. But as I said, I think, first of all, it's incredibly dangerous for a beginner. And beyond that, I still think it's dangerous for me because I think the transection rate is much higher. So this multi-blade is intended to be used to harvest in a strip. I use it to score the dermis. Is that clear? I'm not using this to harvest. So what I'm doing is I use 15 blades for this. I use 10 blades to actually do the harvest. So I'm using 15 for this. And so what I'm going to do, if I can ever get this thing off, there we go, is I load up some 15s. These, I have two here they are. So this is a 15. I think this is a 15. We open up those 15s. And then I place it in here facing away from that area. So what we're going to do is, let's say I want 1.2 centimeters, 1 point, whatever it is. I'm going to do some math here. So anyway, so we're looking at, so this is 2.25, in other words, 2 millimeters by a quarter millimeter. So this is 225, so you can do some math here. This is 225, that's 4, 5, 6, 7, 5, 6, 7, 5, 7, 9, that's 9, and that's 10, or that's 11, so 1.1, okay? So let's say we want 1.1. And this is a little spacer I'll keep on the side, so that's my math. You can always cross-check it. You can also cross-check it by using a ruler at the end and just saying, hey, am I right? And I'll do that sometimes with my staff, they usually assemble this. So I just stick these into this area. Again, I only use the score. I usually, if I have an extra one, I usually like to sandwich on the outside just so it adds a little stability to it. And then I put this down on it. Again, my staff usually does this, not me. And then once I get it close, I want to be careful using your fingers like this, but I usually just bring it up, and I just expose a little bit. I would usually use a forcep. I just leave a few millimeters like this exposed. Now the thing is, when you do this, you don't want to press into it because I only want to score with this. Does that make sense? So let's walk through the mechanics of this. One's a little longer, so I'm actually, I'm just aiming it like this to score, okay? What I'm looking at here is the area I've already decided it with a ruler, with a line. I've drawn it out, as you saw. I've shaved, my staff has shaved it, taped it up, ready to go. I've put in initially the ring block underneath my strip. After that, then I usually like to score first. So let's say I usually just casually mark. I think that's about, I don't really measure it, just so you know. And so I just go and just mark it out like that, okay? So what I'm doing, this is the trick with this. Do not press into it. You want to score both. So how do you do this? So basically, what I'm doing is I'm just scoring. Now, there's no blood trail for me to really see this very easily, but I can feel the pressure on both, and I'm not going so deep that I'm cutting way into it. Can you see the score? Yeah. Okay, so I'm just scoring it, all right? And you'll get better at scoring so that you don't go too deep with it. I'm a little deep on the lower arm, but in general, that's a score. So now I've got exactly 1.1 centimeters. Does that make sense? And that gives me uniformity. Then when I blow it up with tumescence, I know I'm still at 1.1. Does that make sense? And that gives me a very definitive knowing of what I need. Versus with a lot of tumescence, if then you start cutting it, you thought you harvested 1.1, you only harvested half of 0.5. Does that make sense? That's why I like the score. So I use a 10 blade. The one that's from South Medic used to be Persona brand, no financial affiliation for the video. They remain a little bit sharper. Oh, this is nice. There's the rounded thing I told you about. So this is great. The rounded thing gives me a little tactile feel. So what I usually do is my staff standing to my right. Let me give you an overview. They're standing to the right. I'm harvesting. They're dabbing, okay? When I get to the end, I make a vertical cut, and I'll tell you how to do that in a moment. So I make an initial cut about 45 degrees because I'm guesstimating that's a good average, and I'm just making sure I don't go too deep with it. You know, this is hard to see. I may have to have you come around and see it when I go to another one with you guys. I don't really see the transection. But let's just tell you this much, okay? Even though you can't quite see it, I'm just going to use this model as an explanation. So let's say you see this. The hair comes out like that, right? And the bulb is gone, okay? It's up here on the top flap. You just see the top shaft. So what do you do with your handle down? If you just see the bulb back here like that, what do you do? That's it, okay? So that's what you're gonna see that. Just look at those photos in your handouts, your slides that you got. That's what you do. So let's go ahead. I'm sorry this is hard. And when I see a really good example over there with one of you guys, show it to me, and then I'll be happy to show you how I move my hand. But I don't wanna waste time going to find everything, and then I'll come back and we'll come back and show you guys when you find a good example. But I try to pick the worst one. Anyway, so then what I do is I usually use some kind of forceps. That's fine, I just use this here. And I pull down a little bit, and then I just complete this cut. I'm just gonna not worry about transection. So the speed that I'm going really, it's really, you wanna not make it too deep. And this is skiving, it's not good, it's dull already. So what you're seeing, the way I'm doing is terrible. It shouldn't be looking like this. Let's say I've gone all the way to the end. The way you make a vertical cut going down, think of it this way. Think of your scalp in a radial fashion. So in other words, these follicles go out this way, and they go like this. Can you imagine that? Okay. So if the follicles are way lateral, they're here. So my vertical cut goes this way. If I'm closer to midline, my vertical cut is going this way. That way you don't transect the hairs as you separate. Does that make sense? Perpendicular to the hair follicle. So the more medial. And how do you know which one? Well, look. When you look, you're going to see these follicles going in this direction, and it's gently cleaved to separate. Does that make sense? So first, conceptually, you know that you're not going to just go make a vertical cut. You're going to look for, it's like a sliver. You're actually slivering it. So you have better forceps than this for counter-traction. Some will be lifting up, and then I just cut through how far to the base of the hair bulb. That's your limit. Okay.
Do you do the score like you did initially? Do you try to score first and
no,
don't really go through that?
No. The score is only for width. Okay, that's only and for tumescence and for all those things. There's no reason to score this part. So after I've done that, my system wipes everything, moves over to this side because now I'm standing over here, and I'm gonna take this out. So I'm gonna put a clamp on here like this. Okay, so I'm now on the other side of my assistant. I'm taking mets and bombs, pretend these were mets and bombs, and I basically am being very delicate while they're retracting up. Like don't worry, I have to retract this one. But I'm just basically freeing this up, making sure I don't cut through neurovascular blood supply. If I'm near neurovascular blood supply, I'll spread like this, so I don't. And I look at this move. I sweep down blood vessels like this. Okay, and so that sweeping movement, all these little things, it's in the book too, in the videos. So it's on a live patient that I'm doing on. So then I'm doing this where you really, if I have a question of losing a couple hairs over losing a big blood vessel, I'm saving the blood vessel. If it's a minor twig, I may save the hair. So generally speaking, you're pulling back, doing good counter traction on this. Staph is pulling up there, and I'm literally, you see the movement, I'm spreading and pushing down a little bit with it. I'm pushing away. I really want to be just at the base of the hair follicle. It's very hard to see that here. It's okay to have some fat down. In fact, it's good if you have fat to move down. Sometimes you don't, especially for the temples. You're going to be right at the supragaleal plane. You're not at the galea. You're still above it. There's blood vessels going down. You don't want to be at the galea. But as you know, this is sort of getting close. Basically, in this case, it's cadaveric. It's probably galea. But you don't want to really see galea. Or if you see a little bit, it's fine. Toward the temple, you will see it because there's really not much subcutaneous fat. But you can leave a fat up or down. The key is to preserve the bulb and preserve the bulb above and preserve the neurovascular below. And once I get it out, now it's out, then I hand this to, then they put it in PPP. You'll hear that lecture. Don't worry about memorizing that. I'm going to talk about storage media. And then I clamp it to make sure tension is good. If there's tension, I check it first. I take a little bit out. I don't even take it out. I just pull a bit, check. I put all these down. Okay, so I put all the way across to decompress it. I take a 3/0 nylon or a Prolene.
You're closing first, or 1/3 first, and then moving on?
No, I harvest the whole thing. I'm just pretending
okay.
I'm not going to do it for the sake of time. But yes, that's a good question. I harvest the whole thing first. In your case, if you're just starting out in a situation where you don't have anyone, you have a short staff and you're new, then I would take a little bit out, close it, and just see what they do with it. So this is a terrible forceps. I'm just trying to show you this. So what I do is I generally like to, the best thing for a surgeon is to stop thinking like a surgeon, and the best thing for a non-surgeon is to start thinking like a surgeon. Okay, so this is really true. I've noticed that surgeons have their own worst thing, and non-surgeons have their own worst thing. I'm teaching for 14 years. I know which each one is, and both of you can do this. So I like to go a little distal to the incision because I'm not sitting farther away will have less irritation to the area, and then I just tie it off. You know how to tie this, so this is pretty easy. I put in 7 knots. Anything monofilament makes me feel more comfortable. If you don't like 7 knots, then don't do 7 knots. But I like 7 knots. I'm not going to put in 7 knots because you know how to tie knots. If you don't tie knots, I can show you. If you guys are non-surgeons, really learn how to do this with your fingers out of the holes, because look at the angle. I mean, my God, if I need to do that, so the trick is, here it is. This is the trick. Go about mid-follicle. Don't go too deep with this. Don't snag it, neurovascular. Definitely don't touch galea. I go about mid-follicle to a little bit maybe deeper, but not much deeper. And I'm going about 45 degrees. And again, I didn't show you a trick of fitting. Let me do that too. So let's say I'm going about 45 degrees like that, mid-follicle. Now what does that do? It gives me, exactly, it gives me a vertical. And it's a lot easier for my hand to go 45. So you don't see that quite on the first pass, but you'll see one more. Now I'm going to show you how much tension. So first of all, let me show you a trick of fitting in a minute.
And it's always running suture.
It's a running. There's no reason to.
So it's really a full dermal bite.
It is you're in a subcutaneous plane. But yeah, so you're going to subcutaneous, obviously taking dermis. So here's the thing. I'm going to show you. So you see how that just kisses like that? That's not good enough. It's a little bit tighter like that. Just a little bit tighter. Not that. Just a little bit tighter. Okay. You want a little bit tightness. I find my scars feel better with that. Okay. Now the trick of fix cut, which is basically just cutting off. Here. I mean, look, that's exactly what it is. I'm just using you don't need it. You guys can use it, but I don't need it. So I'm just doing that. You see how you regulate? It's fine. I'm just getting that denuded area, and then I just want to make sure that when I place down this suture, that it's actually drawing it down, so that this lip covers that denuded area. Does that make sense? Yep. And you see how far do you space your sutures? You're looking at it. This is about what I do. Roughly half centimeter to centimeter, somewhere in that range here, and you're just locking it down. You see how each of these go down over, and I'm covering that denuded scar. So what I want you guys to do is to practice the following. I want you to practice making the cut and seeing transection. If you can see the transection, pull me over. If I can see it, I will bring everyone there so that we can have a little better demo. Unfortunately, as I said, someone's going to double up on that one. Whoever it is willing to do that. Just don't touch that one. We're going to save for the FUE this afternoon. And then practice for the surgeons that want to practice, as non-surgeons want to practice closing. We can do it. Those that are even surgeons that want to practice, call me over. Let me see what you're doing. I can critique it. Okay. All right. Good. So the trick with following is you don't hold it here because I have no leverage. You hold it here and you maintain a little tension. That way it's less long. If you start to feel like I'm way too long, you can follow here, so I have less. But if you follow way back here, I have no room. Does that make sense? You're usually following about a third. That's called. And I say, can you follow me? Okay. Now look, I'm out. Now how do you go in and out? First of all, this one you're going to learn how to do your practice on these. You're going to push down on this and push up with this without putting your fingers in the hole because it just wastes time. And also you got to angle this and you have to use your right hand. Now I can use my left hand. So I'm pushing down and pushing up. See that? And putting it down. So you're going to practice your non-dominant hand releasing that. That's what surgeons do. Non-surgeons don't do that. They try to go in there with their fingers. Then you grab, put it through, remember what I said, and you're going to go 45 degrees about the mid-follicle, not past the follicle, around the mid-follicle. I'm grabbing here. Now watch this. You see that? This is the trick I want you to do. Not look at this, but look at this. My fingers are out. Okay, now watch this. One finger barely in. Okay, barely in. I'm not pinching the tip, which weakens I'm grabbing. Now watch how I grab. I didn't even click. There's no click. One finger in, and this is out. Grab it through. Now, where do I click? When I want it. One finger's in. Fingers are out. And I just rotated. I'm going to do it again several times. Don't worry. Follow me? So I'm going to go grab. Here, look, no fingers in. All right? Through here, no fingers in. All right? No. Look, one finger in to release, hold. Pull it through without clamping. I clamp. Watch this now. Clamp, double clamp. I'm out. And twisting. Okay, so I'm only one finger in. I started with 2 fingers just to get the first lined up in, and then it's only no finger or 1 finger in. Okay, I'm going to do it one more time for you. No finger. It gives me complete freedom. I don't have to torque my hand. And I watch you do this, okay? 1 finger in. You can grab it. It's better not to grab it. It's bad technique. You'll hear it from. So I don't clamp down. Clamp where I want it. Finger comes out. Rotate. I'm ready to go. A little bit of tension. Is that clear? That's good surgical technique of handling instruments. All right. So we're going to talk about temporal point reconstruction and lateral hump reconstruction. What are these that I'm talking about? So first I have to talk about the anatomy. Think of the anatomy sort of like 2 extremes of balding. So in other words, when someone has minimal hair loss, they may lose some of that temporal point and they may want that reconstructed. But I don't do the temporal point reconstruction unless I have plenty of donor and I don't have other priority zones. In other words, I don't want to build a temporal point when they've got a crown empty, they've got back empty, they've got everything empty for 2 reasons. It wastes a lot of grafts. And the second reason is they'll be front heavy. Everything is up here just placing here. It's all bald back here. It looks crazy. It's more important to get density back here than try to do a temporal point. They've got minimal loss or they're old enough where they've got great donor, then I feel less worried to do temporal point. But remember the temporal point is the single hardest thing to do minus eyebrows. It will look crazy if you don't do it right. All right, so don't do a temporal point. Upper temple, a little more forgiving. Once you go to the lower temple, game over. Lateral humps are on the opposite side of the spectrum. If someone is extremely bald, their lateral humps start to drop. So what's the definition of a 6 to a 7? If Norwood 6 to Norwood 7 is basically a dropping hump. So when that hump drops down, that is the definition from a 6 to a 7. And lateral hump is that upside down bowl, and we'll talk more specifically as we go. So remember the head like a box, lateral hump, temple, all that sits on the lateral vertical plane. Okay? If you think of it that way, you can conceptualize it. If we want to do some more scalps in there and show you flow of motion, I'd be happy to do that. But this is a schematic. Know the subregions. Remember that as that side zone, the mid scalp that goes forward goes to the hump, things change. How does it change? Directions and angles. So if you look at the schematic, This is showing you mainly the temporal point, but it's good to see how everything flows together. You look at the lateral hump coming down, cascading down. The temple goes forward, but then on the front of it goes back, and then when you're really at the temporal point, it goes straight back. Why does it go straight back for? So that's the way nature designed it, God designed it. But also because if you designed your temporal point going straight down, remember I said it's gonna, your hair, if you design those here, it's going to grow on your scalp, and it's going to look like two little weird hairs. They got to go back, okay? So you don't want to design your temporal points going down. So what is a temporal point reconstruction? When do you do it? So the indications, in my opinion, when I've got other priorities that are not there, and I think, you know what, I think it'll look great to balance off, create a very masculine frame, great donor capacity to cover this, other priorities met as I mentioned, and you have an advanced team that can place into this, and you're an advanced surgeon ready to do it. Otherwise, do not do temporal points. Graduate into this. These are very hard to do, but they're easier than an eyebrow. But these levels of difficulty are way up here. Just do hairlines, maybe go to crowns if you can get the judgment, do maybe then advance the females, then maybe advance the temporal points, then maybe advance the eyebrows. That's my way that I help people think of things. Benefits, it's great. It creates a really nice, strong masculine frame and beautiful result. Now, women have temporal points, but they really don't. It's more like a whole temple. So when I talk about temporal points, I'm usually talking about men. So how do you design a temporal point? I don't like this design. It's actually, to me, good in theory. It is in the book, but so I just eyeball the temporal point. So that's really not helpful for me. I don't like the idea of eyeballing. How do you do this? All right, fine. This to me sometimes is a little bit aggressive. So you could start with this as a starting point and then back off if it looks ridiculous, okay? So what it is essentially is you're drawing a line through the nasal tip, through the mid-pupil going up. That's one line. And then the back line is where you want the CAP, central anterior point. Say you want it right here, okay? That's not where there's recession, that's where you want to design it. That through the base of the earlobe are your 2 points. So this in a way is self-correcting. In other words, if you want a more conservative CAP, your temporal point is going to be proportionally more conservative. If you want an aggressive CAP, your temporal point is going to be a little bit lower. In reality, when I've used this technique and not eyeballed it, it looks too aggressive, to be honest with you. It's a good theoretical start, but please don't just, first of all, you're not shouldn't be doing this. You should be at the point where you can eyeball it to do temporal point. If you can't eyeball it, you're still too junior to do this, okay? Just don't touch the temporal point. I think it's important you know the full breadth of hair, but it's important also what you know so you don't touch it. So look at a natural temporal point. Look at people's temporal points when you see it so you understand how hairs naturally flow on it. And so the recipient sites, as I showed you, they go back, especially the lower aspect. And you're using a lot of fine hairs there, mainly 1, some 2s to define that. So you don't want to build a lot of density in that temporal point with a lot of thicker grafts because they don't look right. Here's a recipient site you've seen before I showed. And so there's 2 ways to build a temporal point or a left temple design. You can do a ipsilateral pushing technique up, or because I'm right-handed, so my left side is tough for you, your right side's gonna be tough. Because on the right side, I'm right there, going right side. That's easy. I go to the left side, wait a second, how do I make the left sides? So it's body, what is your body position? You can either, or you can go bending over and make these sides. I've done it both ways, and they both work. I find now I'm doing much more of the ipsilateral push going up because I can control it. And the thing that you're gonna find with the temple sites is that they slide. So when you're making really low angles, they're gonna slide, and when they slide, you're not gonna go deep enough, and your staff won't be able to place into it because the depth is not right. So you have to have a lot of contralateral pull with your 4x4, your cotton gauze. But the ipsilateral push with the cotton gauze to me is I'm able better to control the depth than when I'm bending over and trying to pull this way. Okay, so advanced comment, but again, I think it's nice to hear everything. So upper temple design, we very briefly talked about it in our hairline discussion, just as a reiteration point. Remember that there's a separation of the temple from the hairline, and you're going to have to design it at some point. And what you're doing is you're trying to avoid the lid effect, which means just this huge transplant in the front of the temple sitting way in the back. When do you build the temple? We discussed this to reiterate the point. Remember when we did hairlines, you're having a lateral canthal line go up this way. You're going to take the back of the sideburn go up. That's going to be your most aggressive point, defining a Norwood 2, right? And then you're going to do your CAP and just see if that matches. And that's an easy thing to say, very difficult. But we'll have hairline people to work on this afternoon. You can have all those stations. I'll address that in a minute. So this is the directions of a temple. You know, this is not a clean temple point. You see that without the temporal point, most of the sites go forward and then down. Okay, as they get into the sideburn. So most of those are going to be 2s with some 1s. All right, I really try to avoid 3s in the temple because they don't look great, and you understand what I mean by two hair graft. One is a 1 hair graft. So this is an example of some of the design I've done. And let's talk about lateral hump reconstruction. Okay, this is for advanced baldness because someone needing lateral humps are at a 7, but so 7, your risk is you're going to transplant someone that is too advanced. So am I always doing it with a 7? No, they can be a 6 just starting without hump recession. If you're seeing that little hump recession and you don't transplant, you just put this here. In a few years, it's going to separate. So when I see miniaturization of that lateral hump, they may still be a 6. Because remember, 6 to 7 it's not like 6 one day and then you have a 7. It's a 6 moving to a 7. If there's 6 moving to a 7, they've got a little bit of recession in that lateral hump. I really want to rebuild it. Okay, so it can be a small, an advanced 6 or an early 7, however you want to find it. So it's not necessarily always just rebuilding the lateral hump, but you want to envision the lateral hump sort of like an upside down saucer, right? And remember those angles, they sort of go down and then sort of forward and down. So that first row they go forward and then down. And if you look, the middle section they go straight down. So think of it sort of cascading going downward like this. So I'm going to show you how to draw what's called framing the head versus framing the face. Essentially, what that means is a very advanced baldness where you're designing a little tuft. When, first of all, do I do that? Oftentimes, I don't do that in young patients for 2 reasons. One is if they're already that bald, they're going to get balder. And that design I did is going to look ridiculous. Okay. The second reason I don't like to do this in a younger patient is that stylistically they look better with a shaved head. But it's usually someone a little bit older, maybe 60-some, that they said, look, you know, I never shave my head. I like to wear my little fringe on the back. I just need to get some hair up here, right? You hear this. I just want some hair up here so I don't see through it. I don't like shaving my head. That person, a little hair in the front looks good. Well, where do you put the hair? How do you build this? If they have no hair, they got a 7. This is how I propose it. And it's great. Writing this book, it teaches me how to think to teach it. So this is how it's never been proposed, but it's in the new book coming out. And it's the first time you guys are hearing this new way of doing it. I think this is the best way to teach it by advice. So what you first do is you want to define where that lateral hump position is. Remember that hump is gone. This guy's gone. So what I do is I take that pen, I go up, and I sort of define where the lateral hump is. Okay, so from the side view, I'm going to have the apex of that point. Now, what is the apex? Well, think about it. Look at where that hair sits right now. Can you imagine it going up to hit that end, like a cup, like a narrow cup? That is where that apex is, okay? Because that's the lateral terminus of your hairline. And I do that on both sides. And then I just make sure that it's symmetric from the midline, okay? And so I first define that. Then I define the lateral humps bilaterally. So that's the first thing I do. I've seen this taught, and the first thing they do is draw the hairline. I would argue that if you do that, you're going to place it too far forward because you're going to want to go way up here, and you're not going to do it right. And if you do that, it's going to look weird. I'm going to explain to you why and how. But if you start with lateral humps, it defines where you should place the residual hairline. Again, this is framing the head. In other words, a very conservative hairline. So what now is I then join this island so that there is some hair there, okay? To be very honest with you, this is not a perfect design that simulates real life. It is not quite a Norwood 6. But unfortunately, this is a little bit of a cheat. Okay, it's a way to cheat a little bit. I'll be very honest with you. It's not quite a formulation of it. So what you want to do is just create a joining where this has some frame when someone has lunch with them that they look like they've got hair there. All right. And now you notice that how did I decide how far back to go on this and how far forward to go on it? It depends on the donor supply, I mean, how big the bridge, but it's almost equally weighted on that apex. Can you see that? So it's, in other words, on the top of that's a little in the front, a little in the back. So I would say if you're being aggressive, it's not quite as natural. You can put 2/3 in front of that apex and 1/3 behind it, or the most balanced is half and half. So this is an example if you don't understand what I just said. So if you look, the green drawing is a normal design, okay? The green is what a normal hairline and vertex transition zone and everything. The red is showing you what is when you're trying to just do this conservative lateral hump reconstruction, they've got nothing left, and I'm just trying to build something with what I have. In that case, you see that the red arrows show that it's either 2/3 in the front and 1/3 in the back, or 50-50-ish. The problem is if you start building these aggressive frontal frames and these little lateral humps, it's what's called front heavy. It looks like a toupee. It's too far forward. So be very conservative. You will not be doing these advanced baldness cases for a long time, if ever, and very few of them, because it's risky. Because they have limited donor, you don't know what's going to go with them. And you're going to hear a lot of these fancy talks going, well, you can pull more by doing FUE and strip. No, please don't. You should probably be doing a strip, and you should probably be doing someone older, maybe with white hair, but white hair's tough to dissect. Someone that has a low risk of showing grafty weirdness and that with transitions as they age. The older and the better density and the more conservative your design is your best bet. You got a 32-year-old, this is with an OID 7, please don't do this. He will be a disaster in 10 years that you can't escape on. This is an older gentleman that just refuses to shave the back of his head because he likes some hair. Because the best to me looks like a shaved head, right? But if you can't do that and they want to wear it, this is an exit. Don't think that you don't have that tool set in your belt. Just don't jump to that tool set until you're more advanced understanding donor supply issues. Does that make sense? So this is just showing you the lateral hump again. You see that first row goes forward and then it goes down. I'm mixing 2 to 3 hairs. Now here's a cascade, but again, it may be complicated. I place more 3-hair grafts if I have them high up because they cascade over. But that's the problem because if recessions, you have more thinness on top as it goes down, right? It's counter, right? You're going to hear some people argue with crowns. You should not put a weight in the center because it's going to look too dense. I argue the exact opposite. You're struggling with density in the crown already. And now if I can leverage the cascade, it actually offsets the risk. Because what I've heard an argument for crown, for example, is you should put the densest stuff in the perimeter and not the center. That way, if there's recession, you're good. I argue that makes no sense for the following reasons. It's a waste of grafts, placing the best stuff in the perimeter where there's no cascade ability. And if that starts to thin out around it, now you've got a lateral donor way out wide with no benefit. It's not, I'm more than happy to argue that. I've heard this and I just didn't want to combat the people that said this on, that are in my faculty at St. Louis, but I have approached them, I say it makes no sense. So my way is a way to cheat, but a way that works. But again, when you hear the cascade, it's an advanced concept. Don't place big weighted 3s up here and these minuscule non-existent 2s because you're going to have this weird thing cascading over. It doesn't look right. That's the biggest mistake. Try to place things more or less evenly. I'm just teaching you creativity you can graduate into. And these are just some recipient sites, a lateral hump showing you what I design. And these are just some cases I'm showing you some temporal point designs that makes a person look a lot more masculine. Okay. So summary, understand the spectrum of temporal point and lateral hump. Remember that temporal point is something that if I have great donor hair and I have advanced surgeon, advanced team, that's something to consider. Lateral humps are really for very advanced baldness, like with 7s or 6s going to 7s I'm trying to bring back. And avoid these like the plague when you're starting out. But understand what, you need to know this, but you need to know it so that you don't do it, okay? Full brows are sexy, that's what's in now. The over-pulled look is not as good, I'm sure. Sooner or later it's going to be, again, over-sculpted appearance. There's a function to them. The sweat comes down, blocks it, it creates a little bit of character. Think of Pink Floyd looking, loss of humanity for those that are old enough like me. There's a youthfulness to full brows, so there's a lot of benefits to eyebrows. Indications, obviously, over-plucking. If someone has a weird-looking tattoo they don't want to remove, they want to get covered, you can remove the tattoo. But I leave the tattoo in if I'm going to do an eyebrow transplant if it's exactly over that tattoo because it adds visual density. If they don't like the position of the tattoo, then get rid of it. So that's my criteria to decide whether to remove or not when I'm doing an eyebrow. Congenital absence of eyebrows, great. Traumatic cases where they've lost something from scar, cancer, whatever it be, yeah, absolutely great example. Long-standing thyroid. You don't want to do someone with unstable thyroid, but if they're long-term hypothyroid, things are stable, they don't have hair back, transplant. When not to do it? FFA. If you can't recognize FFA, we're going to show you more slides. Please Google the crap out of FFA. Start understanding it. You're going to see it. It's a rising trend of problems, and you need to really be able to refer it, biopsy it before you touch it. So you're going to miss this, and you're going to miss will be a real problem. Alopecia areata, do not transplant this. Short-term thyroid, as I said, they need to be stable. Do not do it. The grafts won't survive. There are going to be problems with instability. I don't always. It depends, but it's not a bad idea. I think if there's any risk of it, absolutely. If they tell me they've been like this for 20 years and whatever, I'm less inclined. If they tell me I've been losing my eyebrows for about 5 years now, it's gradually thinning. Thyroid functions. Does that make sense? It's sort of a gestalt, but it's always err on the side of caution. Always a good idea. Anyway, so trichotillomania is, and we're going to talk specifically about new therapies for trichotillomania. When to do? I just saw one this week. So it's obviously they're constantly pulling out. You don't want to put it in, but let's save that for this afternoon's discussion. So restoration options, you want to give patients options. They can do microblading, permanent makeup, they can do hair transplant. And you really want to make sure it matches their ethnicity, their gender, their taste, their facial desires, and what makes them look good. If they've got a very wide face, don't make it a little narrow brow, it looks weird, You want to help them be complementary, so that's part of your artistry. I always let them draw it first, which I'll explain in the coming up slide. For us, it takes about 4 to 6 hours. For you, it's going to take longer, but obviously, as I said, it's going to be a while before you can graduate to do this. And then design-wise, if you don't know this, it's obviously with MIM, there's more of a peak, and it goes up for at least 5, 6, 7, 8 rows, and then it starts to go over, and then sort of fishtails and converges before it hits the tail. Okay, so up, over, together. As I mentioned, when you start to do this, it's for the vast majority, unless they're really clear out what they want, I give them the eyebrow pencil to start, and before they're sedated, so that they can draw it, photograph it, document it, and that way they can design it and tell me what they like. Now, part of the time when they do it, it's not symmetric. I just want to know what they like, and then I'll go back and say, honestly, I think you're a little too close. I had one guy wanted a unibrow, believe it or not, it took me forever to convince him not to do it. And sometimes it's too square for. I said, look, I think you really should round this, or your brow's very symmetric the way you designed it. I want this to be a little higher. So I find it much easier for them to initially design it, then let me criticize it, critique it, or offer them ideas of better artistic design, rather than you start from scratch and they go, I want a much thinner brow. I really wanted a square brow. How come you're not doing a peak? I don't know what you want. You design it. Let me critique it. Let me check it in a mirror. That's the one time I give the pencil over. I do not give it for hairlines. I do not give it for anything but eyebrows. But I find it much better for them to draw the initial design. So anyways, hair growth cycle, as you know, it's a little shorter, the anagen, so therefore the hairs are not growing fast, but when you move hairs in there, donor dominance, the hairs will grow as fast as your scalp hairs, and you trim it a couple times a week. They need to know that, especially men who are lazy, they don't want to do this. I do a decent number of men, but men are lazier than women. Women, I don't feel as nervous about it, but men, I always need them to know. Everyone needs to know this. There is some theory that it does slow down after a year or two. I would really undersell that. I asked a pool of 5 people before I went to India to talk about recipient dominance, and everyone said that basically they don't see it consistently. I'm probably in the same camp. I'm not convinced that there's a slowdown in growth from recipient dominance. Recipient dominance means that the skin around that area causes those hairs that should grow fast to slow down. Donor dominance, of course, is the principle of modern hair surgery that we talked about. Harvesting. So you've really got FUE and LSE. If someone wears their hair short and they've got great nape of temporal fringe that I've got to pull from, I'm probably going to lean toward FUE. If they're women with long hair, I lean toward LSE. You know already I use a field block for FUE harvesting. You know that when I harvest for FUE for eyebrows, I usually harvest wide and try to cherry pick the finest 1 to 2 hair grafts. You said, well, we need 2 hair grafts, so that was all 1 hair. I find that 2 hair grafts give me a little more density faster, even in African Americans, just in the central zone, and I use ones around the perimeter. It allows me to get faster results in a single session. I've gone all over the place and I'll sort of explain my evolution as I proceed here. And then you know how I do the anesthesia for the strip already. And then just to reiterate a point, I use 4% septic with 1 to 100,000 epinephrine for my anesthesia. I do a little bit of supraorbital block, and then I do a direct infiltration. It's one of the few times I'm directly infiltrating anything. And as you know, the lacrimal gland's a little bit, lacrimal nerve is a little bit harder to knock out. So it's direct infiltration is the key. And I just palpate, do a little bit of supraorbital block, and then as I told you, I like to inject from outside going in, so I don't smear the lines. You do not want to smear your lines. Eye coverage, you can use either the Curlex or you can use the eye mask or whatever it is. So I used to do perpendicular sites for this because the argument for perpendicular sites is that they write up less, they stay lower, which in eyebrows is absolutely critical. But I'm going to argue that perpendicular sites have a lot of issues. Now, this is going to be a little esoteric. I hope you can follow this. I'm going to try to explain it. So here's the reason why. When you're doing sites at 30 degrees, there's not much competition below the skin. Whether you do perpendicular or you do parallel, you're pretty much good to go. When you're doing eyebrows, they're extremely low. Okay, so this is a cross section of this. So for example, think of it like the eyebrows, the head of the eyebrows here off the screen, and the tail's over there. The parallel sites, because they're so flat, all right, I can get them underneath like this. With perpendicular sites that go this way, super flat, they eat up so much real estate underneath the skin. I can't get them close enough. Does that make sense? It's a sophisticated comment. If you don't get it, I'll be happy to re-explain it. You don't get it, right? Okay, look, picture this being the skin surface here, right? Okay, if I'm making parallel sites, I can get them, see how close I can get them? Really close, because they're low. But if I'm doing perpendicular sites that go this way, how close can I get them? I can't. Now, why is that not an issue when they're at 30-degree tilt? Because when they're 30 degree, there's no issue. When I'm this close, I can't stack them. They're all one layer. You see what I'm saying? So sagittal sites or parallel sites, which is a better word, parallel sites, I can get them much, much closer. In my opinion, you're going to hear a lot of arguments, but this is the one exception where I really think perpendicular sites don't work. Now, I've got great colleagues that do perpendicular sites and get great results. So I just want to explain my theory. So here's another view of it to see how parallel sites can get close and stack up. So that's why I like parallel sites. Second reason I like parallel sites, I can see the design. I can see the flow of the movement because they're following parallel to my design. And it's such an intricate design that when I do perpendicular, I know what the hell I'm doing. And parallel sites don't join together as much because they're not as close. The perpendicular sites keep on joining. So example, when I was doing perpendicular sites, they look like this on the top. I can't figure out what I'm doing. But the bottom one, you can actually see my design, right? You see what I'm saying? And you can see they're closer. Perpendicular sites are very hard. But what's the problem with parallel sites? They're hard to go low. Okay, get ready for the most confusing thing you're going to hear. It's in the textbook. You're not going to understand it. I shot a video to try to explain it, but you still won't quite understand it. So I don't use solid cores. They don't go flat enough. I use hypodermics that bend. The risk of the hypodermic is epidermal occlusion, but I think that using smaller 19, 20, 21 gauge and doing fewer sites, I really haven't seen occlusion cysts with it. But what I do is I need to do 2 bends first. I'll be happy to do it in the lab, but it's very confusing, so that I have the depth correct, okay? And then I do a 3rd bend. This is the one where everyone's brain just shuts down. If I'll show it to you for the sake of completeness, you probably won't understand it. Double bend on the bottom is just for the check, so that the depth goes right, okay? But to get that, I've got to go super low with this big syringe to try to make a site. If I bend it one more time, my hand no longer needs to go low. Is that clear? Yes? Oh, good. Okay, you guys are smarter than the average Jane and Joe. So this is showing you a close-up of that 3rd bend where my hand isn't going to be cocked down for it to do well. I can keep it relatively up. Here's another level of confusion. Which way to bend it? So this is so esoteric that don't worry about it, but I'm just going to show it to you. So the reason I like to bend it in a good way is when my line of sight looks down, that line is not blocking. I see a little bit better. Don't worry. If you want to know how to bend this, I'll be happy to do it. You won't be confused. Okay? Yeah. It doesn't matter. No. Good question. The bevel is sideways. So remember, the bevel doesn't matter if it's left or right. It matters if it's up or it matters if it's up or down. It's become perpendicular. If it's side to side, it doesn't matter which side. Right? That's a great question. It's confusing. We mentioned that yesterday, but it's something very difficult to comprehend. The bevel defines parallel versus perpendicular. It doesn't matter which side it is, as long as it's not up and down. Okay? So then you check the graph, the side fit. I make the perimeter sides first, like a hairline. You don't make it too straight. What I like to do is I toe in a little bit and then I go flat and then push it in. That way I'm really flat. And I don't want to just follow the line. I want to go a little bit outside the line, a little bit inside the line, just to make it not exactly straight. But what I do is when I draw my line in, I will draw the line and let it blur in inside. So I know that I don't go farther out, because if you center the line on it, sometimes you blur out, blur in, and you don't get the right. I want the outer perimeter to be the outer limit of what I design. Does that make sense? So if I'm going to bleed in with a fat marker, I'm going to let it bleed inward. No, I don't care if it bleeds inward. Is that concept clear? Good, you guys are smart. This is not easy to understand. So I do.
Charge more for eyebrows?
Yes,
more difficult?
correct. Yeah, I do. But there's still a lot less in a big case, because it's still a lot shorter case. Yeah, but I charge about half what I charge a full case. But if I charge per graph, it would be like free, right? So I do it first. Do the perimeter first. I usually make 1 hair size. Sometimes, like African American, the 1 hair, 2 hairs they're about the same size. They're chunkier, so I'll do the same size. Sometimes I use a finer one and a thicker one for the middle section. I stagger the line. Remember what I said, degree on or inside the line a little bit. Don't make it too straight, and always check for symmetry. After I've made it, I want to know that they look good before I move on to my 2 hair sides. This is showing you building the inside sides. Again, these are parallel sites. You can see that I'm making these arc up before they arc over, and I'm toeing in, so I make sure I make contact, and then I go in and make it flat. These you cannot make too flat. Even when I'm really, really flat, it's still not flat enough. You need to make these flat. So I start from the head and go to the tail, because I can see the design better by going here and going out. I slightly toe in, as I mentioned before, going flat. And as I progress, I rotate the head. I'll show you that in the next slide. And then I check for symmetry with and without my loops to make sure everything looks good. And then at the very end of the case, after the grafts are placed, let the patient check one more time. This is just showing you I rotate the head away so I can get to that tail without struggling. You don't want to struggle to go flat, because you need to go flat easily. Okay? So I'm using 21, 22 gauge needles, 20, 21, 22 gauge needles for 1 hairs, 19, 20 for 2 hairs in the center, somewhere in that range. These are very fine. So part of the problem is not just your ability to design, it's your staff being able to dissect and place. Very difficult. Very, very difficult. And so in the past, I used fewer grafts with 1 hairs. Then I went to more hairs with 1 hairs. Now I'm doing fewer hairs with 2 hairs. So the 2 hairs give me a little bit more density and still naturalness. And then I inject a little PRP at the end of the case. And then graft placement wise, they need to be well trimmed. They need to, the hair curl is, as I told you, is critical. On the eyebrow, the hair curl is 80 times more important because you've got it all exposed here. If the curl is off, it will look ridiculous. It won't be right. And then they're going to place from the tail to the head because remember, those hairs are stacked on each other. So I designed from head to tail. They place tail to head. Okay. And graft placement, you can do it with all different types. You can use implanters, etc. My staff are trained for forceps. They're very good at this. And then at the end, you want to check, double check, and then show the patients what it looks like to make sure they're happy with it. And the great thing with it, because they're short, they see the design. It's like that. It's like a long hair graft. They see it. But of course, in 2 weeks, it goes out.
Those lower hairs are the native kind of sentinels.
Yes, that's right. Those are native hairs. Right. I don't do a lot of sentinels, to be honest with you. I just make a little stagger at the edge. Yeah.
Sorry, you wouldn't be able to use implanting devices on eyebrow because they're probably too wide.
That's a good question. My friends do. I tried them. I don't like them for that reason. I can't go tight enough. But some of my friends do it. You know, so it's you can ask them if you go to St. Louis. I'll have you ask my friend who does that in the faculty and see what he thinks and see what you guys agree with. Microblading is an alternative. The benefit of microblading, obviously, there's not too much recovery. It's cheaper, but it only lasts a short time and it's not native hairs. With the benefit of eyebrow transplant, as you know, it's hair. The key is you got to match those hairs well, and they got to trim it. Those are the things. And little thinning scissors are the best because they're like shears, like what you get on Amazon. They're easier than actual formal scissors to cut because you can make a sort of regular cut on them rather than perfectly cutting it, and it's a little bit safer in your eye anyways. Challenges, you know all of them. Acute angles, small sites, fragile grafts. The hair curl's got to be perfect. Of course, hairs that don't look right. Of course, white hair is always a challenge. So aftercare, the general idea is you just want to not wash the area for 24 hours. You use a gentle shower. I use ATP spray to help with better improvement. If you ask what the heck is that, I've got a whole lecture on that also this afternoon, so don't worry about asking just yet. And then sutures, if we do it, come out at 3 weeks, as I mentioned. If you've got a little bit of minor problem with the angulation, I used to use an ace wrap to pull it down, but now there's eyebrow wax, mustache wax you can get. These are a couple brands that my staff use to recommend to patients if the hairs are going out a little bit off angle. If they're way off angle, you have to take them out. If they're slightly off angle, this can control the angle and allow you to let it grow a little bit better. Don't worry, you have all these slides. Traction alopecia and eyebrows, this could very well be FFA. If I see a combination of eyebrow and hairline, the first thing I think about is subclinical FFA, and I would want a biopsy. So this is just showing you a patient from out of town that difference gives humanity to the face. This is another example of hairline and eyebrow transplant. Again, the first thing you should think about is possible FFA if you see this before you transplant, even if you're only doing hairline or only eyebrow. That combination is a lethal one if you miss it. Tattooed eyebrow correction is great because you just leave them there and they add better visual density in a single session. Overplucked tattoos and it just looks like brush marks. You want to cover that, but you don't have to remove them. And then just overplucking and they want thicker eyebrows, which is the trend nowadays. You can also do FUE for eyebrow and beard transplant in this area using scalp for the up there, and then using beard to beard transplant for FUE. And then cancer reconstructions, even that small little bit in the tail, even though it's not a perfect take, she did this testimony many years ago where she was in tears about how that made an impact for her. And it's just a few grafts, Disaster, someone that doesn't know what they're doing with eyebrows, they should pluck all of them out and let me start again and redo it because the hair angles were going in 50 different directions. Same thing with this gentleman. His view hair, this is a cancer reconstruction. Things were going all different directions and we had to correct that. This is a gentleman that had traumatic tattoo. This is a little bit more of a feminine design. He wanted to keep that design, so I said, okay, fine. And so the key is that this is a very advanced topic. Low angles are the key. Parallel sites can be placed tighter, in my opinion, even though there's a risk of them being a little higher. And I like using 2 hair grafts in the middle, and you must have a great experienced team to do this, not just your being experienced. Postoperative care. So with postoperative care, I basically have a counseling about the postoperative care at 2 weeks before during what's called a preoperative evaluation. The patients come in, my nurse goes through everything they need to know, and that's really important. I do a preview for them. During the consultation, I overview your aftercare, just so you know, because people always want to know. Postoperative counseling is reviewed at the end of the surgery, so the patients hear it again, and then they come in at day 1 and they hear it again. That redundancy is so important. And of course, instructions are given to the patient, and you have a copy of that. You have all my instructions. They will be on a QR link for the textbook, and you'll also, even my fast consent, but you also have your thumb drive. So you have all my instructions on there, okay? In terms of postoperative care, ATP spray, again, I'm going to talk more about ATP spray, so don't ask me any questions if you don't mind about that. I have a whole lecture on that this afternoon. But I love ATP spray. I think it helps with better graft survival. Again, I'll talk about it separately. They can wear a hat, except, in my opinion, this is my bias, if I've done temples, I'm a little worried for 2 days that they're going to rub on it. But otherwise, crowns and tops, they can wear a hat from the moment they get out of there. 7 days, they can scrub away all the scabs, not pick at it. Some things that can help is you can put conditioners on the scalp or wherever it is, let it soak for a little while and rub it off. If it's not quite good, you can let it soak for longer. But you want the scabs away after 7 days, and the reason is that it doesn't heal quite as well if the scabs sit for weeks. And plus, cosmetically, you want to get rid of it. I have a very low tolerance to consider HBO therapy or hyperbaric oxygen, and I usually like 1 round a day to 2 rounds a day if they can for the first few days. I usually do that if I get a little dusky at the end of the surgery. Of course, nitropase is the first move for that, topical nitroglycerin. But if I have any suspicion, diabetic smoker, a lot of sun damage, the vascular compromise looks a little bit off, I get them on HBO. I've got an arrangement with someone a very short distance from me that's like $250 a dive.
Not a medical grade one.
It is medical grade, but to be honest with you, even ones with low,
Aging type of.
I personally believe that even if the atmospherics are a little bit less than hospital grade, you're still getting some really good benefit. I wouldn't worry too much if you don't have a hospital level atmospheric pressure. I think all of it helps. If they don't have claustrophobia or any kind of contra on it. Activity restrictions basically for me is they can shower gently after 24 hours. It's against the grain. Some people don't like to do it for a week. I'm okay with it. No submersion. This is against the grain. Most people tell me they can start swimming after a week. I don't like it. I just think water is filthy, and where infections occur is basically submersion in dirty water. So I do 6 weeks, whether it's FUE or strip. No workout for a week. I just like to try to keep it away from that. And then for contact sports, FUE is, you can probably do it in a week and not have an issue. I'm just very, very conservative. So I say a month for FUE and 3 months for strip, and that includes skiing or karate or high impact blows. No sun exposure for 3 months. What that basically means is if you go to the beach, wear a hat. If you drive around and go to the shopping mall, you're fine. And I actually say that. So visible scabs are the recipient are there for a week, whether it's a strip or FUE. And visible scabs are the donor for the FUE for a week. You won't see that with the strip. But after about a week, the hairs grow a little longer. Everything is gone. So you're pretty good at a week, 7 to 8 days, whether it's strip or FUE. There is since I've been doing the Bossi formula, I've limited down to about 5% of periorbital swelling. But when it's there, it looks crazy. Okay. And so you just got to when you get that phone call, the patient goes, "I look like a monstrosity." Just it's normal. Okay. So if you see that in a patient, don't freak out. It's just normal. Okay. So if they have enough hairs and I'm placing between the hairs and they do a strip and LSC where they don't see the back and they're not that sensitive, someone may see it, they go back the next day. If they're a surgeon, they can wear a cap on it, they go back the next day. If they're working in the tech industry, they can wear a baseball cap, they go back the next day. If they don't feel good, of course, listen to your body. Okay, if you're a day outside labor where you have to pick up stuff and throw, okay, I would say a week. So I asked that. I need to get the context for that question. If they're doing a FUE and they're shaved and they don't want to see anything, well, they're going to see something. You're going to see the donor. I mean, with a hat, you're going to still see the back posterior portion. Then it's a week of not seeing something. So I want to know what they want to know from me. And when I get that context, I can answer the question better. I always put an exit because I don't want someone to call me and say, "You don't go back to work in a day. I feel horrible." Well, usually you don't. But if you do, I need to know. Okay. And typically, I don't see bruising. Okay, postoperative pain. FUE, there really should be very little pain. With strip, should be very little pain. With the treatment, though, I'm going to tell you, this is a godsend. I told your wife this last night. This has been a revolution. I've invented this technique that's mind-blowing that will help you get your patients after a strip down to a 0 to 1 out of 10. If you do everything right with all the neurovascular type protection, you should have very little discomfort. But day one, the first question I ask my patient when I see them is, what's your pain level? If they tell me, oh, no. If they don't tell me I have none, I'm ready to treat them. And this is what you do. Doesn't matter the brand. I use Zeman because it's a little less expensive. Doesn't really matter what you use. I use Botox for cosmetic. I use Zeman for this. Doesn't matter which brand, honestly. And it doesn't even matter how many units you use. You can use a half a unit, 1 unit, barely a unit. You can put barely anything. It's all position. I do it for migraines. I do it for everything. Foot pain, shoulder pain, finger pain, carpal tunnel pain, everything. Same technique. I've taken chronic neuromas. Patients that have destroyed donor hair from other countries that they have chronic neuroma pain, paresthesias, got them cured. So let me tell you how to do it. If you don't follow exactly what I'm telling you, you will not succeed. Okay? You must follow exactly what I'm about to tell you. First, I palpate. I ask them, where's your pain? One finger. They go right here. Once they do that, I take my finger and I go, you mean here? And they go, yes, that's uncomfortable. Okay. Next, my needle goes in. My needle has to replicate pain. If the entry of the needle, they say, well, aren't you putting a needle in? Shouldn't it hurt? No. It's a 32 gauge. They should barely feel it. If they felt, and they may be numb because that area has been, their nerves are. If they don't feel neurologic pain, some of them don't even understand that until I do a couple points. They go, oh, yeah, now I know what you're saying. When there is pain with the needle entry, I'm golden. Okay? When I push the Botox in, sometimes they'll feel like this. Good. That means the more discomfort you feel, the more I've wiped it out. So if they feel like, hey, it's better, then the pain will be gone. You won't believe this. That's actually too slow. The pain is that fast on. Okay? Then what I do is I just tell them all the points where it's hurt or when you lie down it's hurt, and I wipe out all the pain. It's very magical.
This
Okay?
is acute treatment, right?
Chronic neuromas.
So will they come back?
I don't create chronic neuromas. Okay?
Will the patient come back for more Botox injections?
No, once. It's one and done. Now, occasionally, very, very rarely, I would say, first of all, I only do this in 5 to 10% of the patients, but out of the 5 to 10%, 5 to 10% of those, they declare other areas. So they have an inflammatory area that they go, this is what happens with their nerves. We have 2 that really bother us, for example, okay? What I try to do is I hit 10 areas. Actually, once I knock out what they complain of, I go back with my finger and touch every point. And they go, oh, wow, there was a tender point here. I hit that point. I hit this point, hit that point. I hit everything I can hit. That way there's less chance of the relapse, because the relapse is not a relapse. It's I didn't knock out all the pain. If you have this glaring pain screaming at you, you don't feel those. So what I do is check everything. So what I get with those relapse rare cases is because I didn't hit every pain point. Does that make sense? But they won't come back.
Are you diluting the same as you do your
Yeah,
prosthetic?
4 cc's.
For 0.1? Yeah.
I'm putting 0.02 to 0.05 per site. Barely a breath whisper. It's all technique driven. If you are not getting extinguishment of pain in 1 second, you have missed it. If you're not following this 4-step way I'm doing it, you have not listened to me. Okay? I've taught this to people, they don't hear me. I've taught this in every academy, everything, they still don't hear me. They can't reproduce this. It's not because it's a bad technique, it's if you're not listening to me. Okay? You must do this stepwise. If you don't hit it right, you will get no result. If you hit it right, they're clear.
So this can extend to like basically any part of the body, like conjunctivitis, tonsillitis.
I treat it all. Okay? I just had my TMJ shot down last week. It's amazing.
How are you mixing?
I do a 4 cc dilution. I do that for my cosmetic, and then I just draw up 0.2 to 0.6 to 1, depending on how many points I'm thinking. Remember, each 0.1, I'm putting in 2 to 3 points. It's a very small amount. You don't need a lot. So it goes against the grain because I'm using almost no units, and I'm getting immediate relief that lasts. You don't believe it. I've had these people with chronic neuromas. I inject them every 3 months, not my own patients, but chronic neuromas. I do them every 3 months, and after 4 rounds, the chronic neuroma's gone. No excision. Don't believe this as general surgeons, right? You think I'm totally lying to you. I know you don't. Until you try it. Okay, that's going to save some lives. 1 day after FUE, I just check everything is good. 3 weeks after LSE, I take out the sutures. I do a 6-month check, a 1-year check. Out of town patients, I just have phone calls and calls to check on things. When hairs grow, maybe as early as 4 months, maybe as early as 5 to 6 spotty. It's really 8 to 12 months that you're seeing it, maybe up to 18 months. That's really that's the golden period. Management of complications. Here's the problem with dislodged grafts. They don't survive. Sometimes I put them in, but it's 3 minutes out, they're dead. Okay, and so honestly, don't bother. But if patients, I lost 2 grafts, just explain you lose some grafts. What I do is, if I'm doing eyebrows, if they're bitching the next day, I actually keep grafts in ATP for the next day in case they want 2 more grafts or something like that. So ATP does keep the grafts pretty intact. Again, you'll hear the lecture on that and the data. Hiccups. I occasionally get a phrenic nerve irritation. That's pretty rare, but occasionally I see it maybe once a year. What you do is you just take 20 milliliters of Maalox mixed with 10 milliliters of viscous lidocaine and have them down it, and then wait an hour. If it's still there, do it one more time. Usually within 1 or 2 rounds, it's down. Or you just give them a little bit of a cocktail, go home with it. They don't want to wait. It's all, again, you have all these slides, okay? Bleeding, if they're bleeding during the surgery, the TXA, either an oral dose or an intravenous dose is nice. For strip, if they're bleeding on the backside, you just put an ACE wrap, put a 4x4 on it, take it off before they go to sleep so it doesn't ride up on the grafts. Don't make it too tight, don't strangulate tissue, don't cause necrosis, but just gentle, good, firm pressure on there can help minimize any oozing. It's usually occipital artery, or not, venous oozing. For recipient areas, if they're bleeding, you just tell them hold pressure for 5 minutes with a stack of gauze, and then they'll stop. So, or just recheck it. Of course, look for blood thinners, BP as etiology. Usually, the epidermal cysts, a few of them they're just going to be there. Occasionally, it's going to be there. They're going to go away. You want to rule out an infection, so you can culture will be a great idea. A little mupirocin, hypochlorous acid spray is great, but not a big deal. Surgipro Heal makes hypochlorous acid. I actually did hypochlorous acid almost on all the post-op patients, but then now there was some literature citing that it could compromise graft growth, so I decided, okay, fine, I'm not going to do it. So what I do with hypochlorous acid, I didn't show this, and once I have the wound open, I spray a little bit in there. If you don't know what hypochlorous acid is, it's basically, it's a neutral salt, so it's not going to hurt you, and I just, like when a patient comes in after chlorhexidine, I just spray them before I start doing things. I do it for fillers, I do it for any small procedure in the office. I spray down with hypochlorous acid, it has no toxicity, it smells a little chlorinated, but it's not bad. Rule out antifungal. I sometimes send them home with hypochlorous acid to spray their scalp a little bit. I know it can theoretically cause graft tissue. I don't think it is. If it's a decent infection, I would rather just have them spray a little bit on there. Obviously, look at clean towels in the gym, et cetera. Avoid water submersion, as I mentioned. Vascular compromise, I already mentioned this. You want to avoid dense packing and not enough tumescence in that area. Use nitro-paste with a very low threshold. If you're looking at any dustiness, tell your staff is replacing if you're out of the room when you go back in. Make sure that they tell you, look, we need to put some nitro-paste on there if we need to. Warn them they can get some headaches with it. It's normal. I don't believe epinephrine is the culprit for vascular compromise.
Are you seeing the dustiness on your
Scalp, recipient area.
recipient? Okay.
Right. Then I told you about the post-HBO, hyperbaric oxygen, and possibly start the minoxidil again after a week to help with vascular issues. I don't think it does a lot, but it's nice to do it. If you have an eScar there, don't debride it. I really haven't seen necrosis since I stopped micropunches many years ago, but it still can happen. So you want to be really careful with this. In terms of effluvium, I already told you this for the women in particular. Pre-op counseling is so important. I like about 6 weeks of minoxidil on there. If they're not taking long-term minoxidils, I mentioned don't have them take it, otherwise it's going to grow some hairs that you can't read what's there long-term. I told you about fibers 2 weeks early on. Don't be careful. You may kill grafts. Yes, I'm sorry. The follicle that I made, I think it's great for hair shedding. Hairstyling options, I told you about all these things as camouflage. Hypertrophic scar versus keloid. Hypertrophic scars, I basically use 5-fluorouracil to kinolog, triamcinolone, 10 milligrams per cc in a ratio of sort of 3 to 1, 0.6 0.6 to 0.2 milliliters. I just inject it into the scar. You don't want to be subcutaneous. Sometimes in darker skin patients, like Hispanic and darker, you can have a little violaceous discoloration. That goes away in a few months. I put sub-Q. That's wrong. It should be intradermal. It should be intrascar. Okay, and I do that every 3 to 6 weeks if possible. You really shouldn't see this, but I'm just saying in general, this is what you would do. Keloids are much more menacing. What I would do with that is a 1-to-1 ratio of triamcinolone 40. Again, it's not sub-Q. This is wrong. It should be placed into the scar, and that I would do every 3 to 6 weeks as well. Pressure may help, but again, if you've got grafts, you got to be careful with that. I do a lot of keloids in my practice, and for me, if you don't know the literature, what has worked for me is excision plus time radiation within 72 hours. New literature shows 72 hours may actually even be better than doing it within 24. I used to do everything within 24, but you can take a failure rate where it gets significantly bigger to at least barely there, maybe less than 10% failure, down to 5% after a year. And then if it's an earlobe, I would do like a pressure clip on it. That brings it down even lower if they need to, if it starts to come back. Natural results, cobblestoning, which fortunately I rarely see, which means the grafts are placed a little too high. You can do a little cautery or sharp dissection to cut it off. Pitting kinky hairs, you either have to take them out or you've got to place better grafts in front of them to cover them. A natural hairline, if it can be lowered, put better grafts in front of it. If it can't be, you've got to either punch them out or surgically elevate them.
What causes the kinky hair?
So one of two reasons. Either subcutaneous fibrosis due to dense packing and there's a strangulation of the graft below, or traumatic insertion of grafts. Or using pubic hair into the head. I'm just joking. Which actually, if you don't know that, the first 1939 was scalp to pubic hair from Japan.
Scalp to pubic hair.
Yes, because because of public bathing in Japan, there's a disease where there's a loss of hair follicles in the pubic area. Considered if you're a young female, it looks like you have disease, so you didn't want to do public bathing. So that's the first one. Occurred to Tamura in 1939-42. Both published that during the war. Didn't get released until after because it was a war. It was published in Japanese. So that predated Orange work in 52. Just out of curiosity, but Orange is really one that's refined the concept of donor dominance. Anyways, that's enough history. So pore growth is really make sure you have meticulous records of who placed where, which side, and that's why it's better not to have staff rotate around, place some here, place some that way you can see who did what. Consider biopsy, rule out scarring alopecia, use minoxidil to help with if it's early on, that's why it's good to check them at 6 months. Consider second surgery, adjusting depth, adjusting technique, and rule out progressive miniaturization as a cause. Patients are just progressing. I recently saw a patient who's not on medical therapy. Within 3 years, he looks a little balder than I did a surgery, and I looked, and it's all grafts. Everything else receded. So he just needs more surgery, and he needs to be on medical therapy. So look for that. At least a year. That way hair grows in, scars relax, everything like that. But it could be longer. 18 months would be a good time too if you're not in a hurry because it gives you that last 5 or 10% of growth. So what I'm going to do is I'm going to do an eyebrow, which I know is an advanced topic, but it's great to have this memorialized in the video series as well. Okay, so what I'm going to do here is just show you the eyebrow design. So basically the sights go sort of up like this for 4 to 5 rows or so, and then they start to go down like this. It's hard to see this way, right? But then you'll see it when I design, and they go like sort of fishtail, they converge, and then they go down like this. So let's go ahead and bend the needle. This is the confusing thing. So I use hypodermics. I don't use one this big, but this is what they have in stock, and it's fine. And so what I do is I measure the graft length. Part of the problem with the large 18 gauge is you can see that the hub goes as far. You really can't bend it shorter because it's going to crack. You need to at least get it as long as this. So what I do is I go to the crotch of the needle driver because you bend it here, it's too flimsy. So I go to the, you see that I'm all the way to the bottom, and then I first measure the graft length. Let's say the graft length sits about right there. So what I'm going to do is I'm going to put it about here. I measure the graft length, and then I bend it away. Okay. So I'm looking at the bevel. I bend it away. This is in the book. All right. I actually show this. So then I take it here, and I bend it back. That move, which is so easy, is actually, when you do it, I guarantee all you're going to be so confused. All right, I don't know why, but I've done this and every student seems totally confused. That's the first bend. The third bend is what I was telling you. Okay, that's the one that's very confusing. So I bend it this way, and the reason, when I connect it here, I can make sights very low. Can you see how my hand doesn't need to go? I don't need to go like this. And I bend it this direction so that, remember, my line of sight is not blocked by this. Can you see that? It's over here. And so how did you bend it exactly? So what I do is after I bent it, I bend it this way, I think. Okay, I want this line of sight to be good. Now I just bent very quick because I'm used to doing it, but you're not going to be used to it. You're going to think, well, I want this over here so my line of sight is open. So then I can hold it there and then bend it. Does that make sense? So that's why you can remember which way, but it doesn't really matter now, so you can see just fine the other way. All right, so now let's say I've already outlined the eyebrow. We're just going to do one eyebrow. We can do both. I think that's a waste of time because you have a lot of things you want to do over here. So I had the eyebrow outlined. I know this is not the most gorgeous eyebrow, but let's say that's, of course, the peak should be over there actually. So let's say that's the eyebrow, okay, that I'm planning to design. Remember that when I start, I always do the perimeter first. And when I do the perimeter, I usually like to think this outer drawn line is the outer limit of where I want to be, okay? In other words, if I go here, the eyebrow will be too small vis-a-vis the other one, and when I'm drawing it in, as I mentioned in the lecture, if I have the eyebrow initially drawing with the eyebrow pencil, I'll come in here and I will make it darker with this gentian violet or marker, making sure that I don't actually bleed it out like this, that the lateral limit or outer perimeter is equal to the outer limit of the perimeter of the eyebrow pencil. That way I know exactly that's the biggest size I want it to match the other side. So here's what I would recommend. The next thing, how do you do this, okay? So I go in, toe in, okay? And then I go flat. Do you see how flat I am? Mm-hmm. I am so insanely flat. And then I stagger in a little bit like this, and then I come back out a little bit, so it's a little staggered. I really don't go, unlike a hairline where I'm really, really exaggerating the staggering. When I'm doing an eyebrow, there's very little staggering because otherwise you're going to create a really bizarre looking eyebrow. So I don't do a lot of staggering. I just go sort of in and out a little bit. And then as we start to go here, remember these arch up, these start to go down. So these start to go down a little bit. But look at how flat I am. This is the thing, the biggest mistake. There's two big problems with eyebrows is you don't go flat enough, and you also do not, you don't follow the complexity of the design. And that's really, really important. So what I always do is I start from the head. I come up and do the top. I almost do this every single time. I've done like 2 or 3 eyebrows even this last week. So I come in and just go across there, across like this. And then, as I told you, I sometimes rotate the head this way to maintain a low angle, so I don't have to go put my hand down. I'll turn the head a little bit so I can access the tail. And then what's really important when you get to the tail is for you to look at the shape. Is it a fat tail, short tail? Is it a tail that requires just one point? And then what you want to do is after you've done the side, when you do the other side, is go back and look at how this tail looks. You don't want the tails to look really different. Now, as I come back across here, I start, you see how it's fishtailing in? It's aiming, oh, sorry, it shouldn't go through like that. But anyways, so I'm going in, and then I say, oh, that's not staggered enough. I'll come back and do a little bit more here. And so this is just showing you, fortunately, recipient sites are like watching paint dry, but it usually takes me about 20 minutes. Yeah, exactly. That's right. So I did make a circle. That's when I do this. So basically what I do, and I look at this, I'm starting to go up because I know this part is the part that's going to arch up. So I go medial to lateral, lateral to medial on the perimeter, and then I fill in the body going medial to lateral. So that's this thing. At the end, I'll go and check, is it staggered enough, not staggered. Like that looks a little too linear. I may go put one here, or I may put one there, but I don't want it too staggered, okay? So then I check both, I do this, I do the other perimeter. I write down 82 ones, 83 ones on the other side. I check both symmetry, and then I take maybe sometimes a larger needle, and then I'll start here. Now, the key is the first 5 rows or so, they're all going sort of up. You see, I toe in, and then I go flat. I toe and I go flat, and to me, it's much easier to design medial lateral. Remember what I said, that when I'm doing the when the graft placement's done, you got to go the other direction because the grafts sit on one another. So you got to go lateral to medial. But I'm just going up like this, and you really got to go flat. I will promise you this is the hardest thing because you've got to get the right design, you've got to get the right density. You can't interlock the site. I mean, you can't join the sites, and you have to go flat. And so now, as I get into the 4 or 5 rows, I start to curve down. I'm not going to do the whole eyebrow because it's like watching paint dry. I'm just going to get you to the point of a convergence pattern. You can imagine the rest. And of course, if you really want to do the whole thing, I think I'm taking away from your lab experience. But if you really want to do it, I can. But this is, and I'm pretty certain I've done this. This is also diagrammatically done by Mason in the book too, so it really helps. But you see that now at this point, I'm starting to converge. I'm starting to get these areas to come down and converge. You see that? So now, you see the convergence pattern starting to happen? So these are, in other words, the top is going down about 30, 45 degrees, and the top and the bottom is coming up 30, 45 degrees. They're sort of meeting in the middle, like a fishtail. That's what's happening here. Okay, and that's just continuing all the way down, all right? And that just continues like this, right? Where they look like this, so I can rapidly do this, not waste more of your time, but it's just going in like this, okay? I mean, I know they're not, it's beautifully done. So that, you know, of course, are holes here. I'm just trying to show you, okay? Does that make sense? These go this way, okay? But that's an eyebrow. So where I sit, one more thing, when I'm doing this on this side, I'm sitting here on the patient. When I'm doing this, I'm sitting this here on the patient, and then I start to turn over to do that, because I'm right-handed, all right? And the trick with using hypodermic needles is get a lot of them, all right? So I usually use like 4 to 6, and for something as few as these sites, because there's a lot of delling, especially this low angle. So I will, let's say I'm doing 19 gauge for 2 hair grafts in the middle, I may have 5 of them already bent. So what I'll do is once one is bent, I will look at this one, so I'll say, okay, let's say this is already bent, right? I look at this, I put it here, I go, okay, well, to bend the next one, I need about that much exposure to the tip. So what I'll do is I'll take all of these, I'll put them all out like this, I'll throw them all out here, and I'll go, okay, well, that's about this length. So that means I need about that much exposure there, roughly there. Bend it, let's see if I'm right or wrong. So I'm pretty close, you see that? Because I've done this many times. And I just bend it and bend it. You're not going to bend it this fast, you'll be very confused, trust me, but I'm ready to go. So I go ahead and just open like 10 of these and bend all of them, so they're ready to go. Another trick, for all the discard needles, I have a little medicine cup. I just toss them in there, so all my sharps are going in, and that way I know what's used and what's not used. At the end, I just dump it in the sharps container, okay? All right, so we're going to talk about storage media, and we're going to talk about it in the context of why is this important in terms of graft survival, how you handle your grafts. So why is this topic important? I think it's important because you get good graft survival, and that's the key. However, there are major factors and there are minor factors. The major factors in terms of graft survival is how you handle them: transection, crushing them, dehydration. I told you 3 minutes before they're dead. Ischemia. Minor factors are really going to be the storage injuries that we're going to talk about in detail. Ischemia, reperfusion injury, what that means exactly, and just miscellaneous factors. So on a larger scale, it's a smaller factor. However, it's still an important one. So for me, it's sort of the spectrum in terms of regenerative medicine and storage media. Regenerative medicine is a term to describe. I use the word fertilizers in a colloquial parlance to describe this to patients, so they know that these are things that just help graft survival in terms of like storage and things like that. So if you think of it sort of like a spectrum, you can think of it as 2 sides of the same coin. And then if you say, well, what are some examples of this? So in storage media, it's going to be hypothermosol, ATP. Regenerative medicine, you could argue it's ATP or is it PP. So you can see they're almost similar things. They're all, are these storage media, or are they really helping graft survive a little bit better? Well, yes. So we're going to sort of break down storage media into more specific components. So we're going to talk a little bit about what defines extracellular versus intracellular. We're going to talk a little bit about pH, the importance of pH, temperature. Should it be cold storage? Should it be room temperature storage? Energy and nutrients for those cells. What's going to help time out of body as well. So from a storage injury, what is storage injury? It's basically any time a graft is taken ex vivo out, that is going to cause storage injury because that graft has now been taken out. And what is occurring in terms of this cascade mechanism you take out of the body? It has immediately the storage injury, which is basically a conversion of aerobic to anaerobic metabolism, a drop in pH, an influx of intracellular calcium and sodium, which then causes intracellular edema, which then programs cell death, which is called apoptosis, which only gets exacerbated with increased time out of body. A second type of injury is cold injury. So when you have cold injury, when grafts are chilled, you say, wait a second, are grafts supposed to be chilled? We're going to get to that. What happens is you get this influx of calcium and sodium, and then an exit of potassium, which causes cell swelling, and that cell swelling could cause lysis or death. So here are the pros and cons of low temperature versus room temperature, and I'm going to tell you what I do with this, and it doesn't mean you should do it this way, it just tells you some of the pros and cons of each. So obviously low temperature, the reason why classically people chill their grafts is that there is lower metabolism. With lower metabolism, there's supposedly going to be less of a risk of these kind of metabolic injuries that we're talking about, but it does induce cold injury, which we just talked about that mechanism. Room temperature, you increase metabolism, but you decrease the risk of cold injury. I use a little bit of both methods. I'm going to explain to you how I do it more specifically, so we can hopefully get the best of both worlds and minimize the worst of both worlds. The final type of injury is something called ischemia reperfusion injury, which essentially means when a graft is taken out, it undergoes ischemia, in other words, loss of blood, and then when you put it back, that activation causes a cascade of metabolic problems of free radical damage, and that's another element to the damage. So the whole cycle, if you understand it, goes from a storage injury plus or minus cold injury when it's going into the holding solution, and then when it's brought back into the body, it undergoes what's called ischemia reperfusion injury. So what we're trying to do is minimize these types of injuries to the graft for optimal improvement in terms of survival. So there are 2 types of holding solutions that are out there. There's what's called extracellular and there's intracellular. What do these terms mean? The terms mean that that's what it is balanced to. So in other words, it's balanced similar to what the extracellular environment is versus what's the intracellular environment. The extracellular balance solutions are classically the things you're familiar with. They're basically intravenous solutions such as saline, plasmolite A, and Ringer's lactate. And intracellular solutions are what we would consider fancier tissue holding solutions such as hypothermosol, Viaspan, custodial HTK solution. Why would potentially intracellular solutions work better? Remember that whole cascade I just showed you. Influx of extracellular products or metabolites going in, causing an influx of increased swelling and issues. But if it's intracellular balance, and this is its extracellular solution, it may cause more balance. Does that make sense? Because that way you don't get an influx of extracellular things. They're almost at equilibrium already. Okay, so the second component is low pH versus physiologic pH. So if you look on this, out of the three extracellular solutions, plasmolite A has the best pH balance that you have. Does that mean you shouldn't use saline? No, saline can be used. Does it mean you can't use RL? Not necessarily. But if you have a choice, maybe plasmolite A may be a good option, or buffered saline, especially if you're not willing to invest in something a little more expensive, such as hypothermosol. And so what's really wrong with saline? Limmer, back in the days of just doing strip cases in the late 1980s, showed that there was a huge survival of grafts and saline. In fact, for many years I used saline and got pretty good results. So it's not a bad thing to use saline. If your staff or you're using it, it's not necessarily wrong. However, normal saline has maybe some risk. And I'm going to talk to you about, especially for the beginners, why these fancier storage media may actually be even more appropriate for the beginner. And we're going to cover that as we go forward. So the real problem with saline is that these are small studies trying to tease out small differences, and they're short time frames versus grafts that are over a longer period of time. So what happens when we look at a short period of time? Is it okay? Yes, but as we start to extrapolate that time longer, you can see that the saline arm starts to drop precipitously quite quickly. Now, if you start to look at immunofluorescence studies with hypothermosol, you can see that there is a good viability of that immunofluorescence even days after it, whereas if you look at saline, it's pretty much crapped out incredibly fast. Within hours, it's not as viable. Same thing if you're looking at a trypan blue stain, which looks at tissue viability. You can see that saline after 5 days is pretty much toast, whereas hypothermosol grafts look decently good at that point. In vitro studies looking at dermal papilla survival at 2 weeks in vitro at 4 degrees C shows 0%, as you would imagine with normal saline. Pretty decent with hypothermosol alone, but when you have hypothermosol and ATP, you actually have a 94% survival at 2 weeks on this in vitro. That's pretty crazy, right? And then in terms of hypothermosol ATP, what is it doing? Why are there, to me, that's like Reese's peanut butter cups, they're good together, and I do them together, and the reason is that the hypothermosol, as you already heard, it's an intracellular balanced solution. It helps with those kind of injuries that we talked about, and ATP is an energy source, and what it's really trying to do is stabilizing the sodium-potassium ATP pump, which is minimizing that influx and cell death apoptosis. Okay, so the two together works really, really well. So the hypothermosol ATP study by Jerry Cooley looked at grafts stored in 5 days at 4 degrees centigrade in hypothermosol ATP. So that's a long time out of body, right? So who is going to leave something in that long? What was very interesting is this is a temple of the hair that had irradiation and surgical excision from basal cell carcinoma, and he transplanted the grafts into that side using ATP hypothermosol, and he transplanted the good side using normal saline. So the side that has no radiation and surgery, and this is the survival that he was noticing in the difference. There was a much higher survival with ATP hypothermosol, even in a more compromised zone. Biener here did a study over a long time, 96-hour study out of body time, comparing, this was in 2011, comparing the two, saline versus hypothermosol, and almost every time point there was improvement in survival compared with saline up to 96 hours. So the natural question is, why am I talking about 96 hours? How the hell long is your surgery, right? Well, two things. One is that if survival can be better, even if we're teasing out small percentages, that's a good thing. Second of all, I alluded to this in a couple previous talks, telling you that I will go into it in more detail, which I'm doing now. But you guys are starting out, you may find at the end of the day, you're exhausted, it's 10 p.m., your grafts are still out, and you're wondering what to do. And should you run it till 5 in the morning, or should you come back the next day? Well, if you had planned ahead and tell the patient, hey, this could be, this is most likely, you say it's most likely to, and they're 1 day they're shocked, and say, we're planning for 2 days, it's a bigger case, even though maybe a smaller case, and then you already harvested and you over-harvested and you got these grafts, stick them in hypothermosol ATP, you have a better survival by the next day. If you're in saline, they're probably dead. So this gives you a little more flexibility. As I told you with my eyebrows, sometimes next day they have a few grafts, you want to put a few grafts in, I have those grafts ready to go, I can put them in. So ATP hypothermosol gives you a little more flexibility, especially when you're at the beginning phases of your career, when you may have longer ex vivo time than someone that has a more efficient staff. Does that make sense? So I think I like that. Also, as I mentioned in the earlier lecture, in the post-op one, as well as I mentioned, I think in the eyebrow one, I use post-op ATP spray. How do I mix all this? I have a chart that I'm going to show you in a minute that will break it down. All of this is in the new book. It's also in your form if you're welcome to take a photo too, but you have it all. So I basically have them spray this ATP spray every hour until it's gone. It takes between 2 to 4 days to be gone. It's every hour while they're awake. So for me, the major regenerative technique storage media that I use are hypothermosol ATP, PRP, PPP, which is platelet poor plasma. How do I do all this? So this is probably a nice little chart. So essentially, I get the ATP in 50 milliliters. From that, I take out 10 of it and mix it with 100 milliliters of hypothermosol. That becomes my graft storage. On the other side, I take the 40 remaining, put it into 400 milliliters of plasmolite, and then I split that down into 300 milliliters. That's going to be for graft spraying to keep it hydrated, and then I'm going to have 100 milliliters that I give to the patient in bottles to spray on the recipient bed until they have no more. Okay. Now, beyond that, remember I teased a little bit earlier about cold storage, chilling, ATP. What do I do? So basically, the easiest way to think about it, PPP is physiologic. There's an Indian doctor that presented this stuff that I thought was pretty interesting. And so what I do is the PPP I don't inject. I use it as an initial physiologic storage medium because the thought process is, and it may be wrong, but this is what seems to work for us. It's what I've learned is that when a piece of tissue comes out, there's an initial shock to that tissue. If I can get into a physiologic bath without shocking into a cold storage like this, there may be a little bit better. So what I do for my FUE grafts and my initial strip of LSE, I'm going to put it into a PPP bath at room temperature. Okay, so the PRP has already been spun down, concentrated the PRP and separated the PPP. So I'll have all of it at room temperature. My PRP sitting in the back table ready for me to inject at the end of the time the recipient sites. I'll inject the PRP at the end of my recipient sites for strip. I'll inject the PRP at the end of the FUE harvest, because remember I did the sites earlier, and I'll put that right before graft placement. I basically do it right before graft placement. But the PPP, I will put my grafts I harvest out initially with FUE, be placed into the PPP, brought into the sorting table, and then when it's sorted and trimmed if necessary, segregated and lined up, that's placed into ATP hypothermosol. For the slivers, they're basically taken out and then slivered down at room temperature of PPP and then placed into hypothermosol ATP and then chilled at that level. Everything in ATP hypothermosol is chilled. So it's a sequential physiologic room temperature PPP bath moved into a chilled ATP hypothermosol solution. Okay, so you get the best of both worlds. Is that the right way of doing things? No, it's the way I do it. Okay, you may find, hey, I like to chill grafts right out. I like to use saline. No problem. This is how I do it. So you saw some of these examples. This is one case where it's already growing very well in scar tissue. This is a radiated brain surgery operation for a brain tumor with chemotherapy causing this. And this is one surgery to get this result. This is a basal cell cancer with a skin graft. This is one surgery to get this result. So I think there's, besides good technique, there's some good growth with this. So good technique is much more important than any choice of storage media. Storage media are a minor issue, but I think it's still important to cover. Saline is a very workable medium to use if need be. Plasmolite may be better. It's not that much more expensive. Hypothermosol ATP, in my opinion, works very, very well, especially for longer overnight cases. And as the 2021 president of the American Board of Hair Restoration Surgery, I encourage you, as you start to develop into your career, to consider becoming a diplomate in the future. Scalp conditions relevant to hair surgery. So I've sort of divided these into a hodgepodge or potpourri of topics. They're not necessarily embracive of everything, but they're meant to sort of stimulate your thinking. So one category would be androgenic alopecia, which basically means male pattern baldness or female pattern baldness, non-androgenic, non-scarring hair losses, and we'll explain some of those examples, scarring hair losses, and then traumatic surgical alopecias, okay? I am not going to talk about this because we spent 2 days talking about it. I only put it there for the sake of completeness. So we're going to talk about some examples of non-scarring alopecia. So this is important because I've heard even when my esteemed colleagues lecture saying traction alopecia is a scarring hair loss. That is incorrect. Traction alopecia is not a scarring hair loss. Alopecia areata is not a scarring hair loss. And what defines that? There's no subcutaneous fibrosis. It is not. It doesn't have that. So it's a different mechanism. So traction alopecia does well with graft survival. It's like an androgenic alopecia. So let's break down each of these non-androgenic, non-scarring alopecias. So first of all, trichotillomania. What is it? As everyone knows, it's excessive hair pulling out. And usually you see this patchy loss in a zone over here. It usually spares the hairline because the person it's too painful to pull the hairline out. Usually it's more on one side or the other based on the patient's predilection to pull. It's a type of obsessive compulsive disorder, and it's usually should be treated with SSRIs and treated under the care of a psychiatrist, psychologist for therapy. The key with this is two things. One is that I heard Maria Schambach give this brilliant lecture last year. Whoever was, did you hear this lecture? Amazing lecture. I actually stuck it in my book right before this. It was already laid out, which is derma rollers. It doesn't really matter the depth, maybe 0.5 millimeters, whatever it is, stimulates the sensation of hair pulling. So what was really cool, if you haven't heard this, is that she found almost zero relapse except one person that forgot to bring the derma roller on a trip. I guess an Amazon Prime it over here. And so, which you can obviously. So the trick with this is the great thing is derma rollers stimulate vascular growth and stimulate hair growth a little bit versus destroying it, right? So if anytime they have the sensation they want to do, they should replicate it with a derma roller. Clearly, do not operate on them if they're not under good psychological care, if they're not on medical therapy, if they don't understand that they can have recurrence or they can tear out their own grafts. So that's all important, okay? But it's not something you cannot operate on. I have operated on it, and but it's just something you need to know all of these issues. And now with derma rollers, I think it's a fantastic first pass. I would not operate on them if they're not on a derma roller of some kind. So, of course, I think they should be an SSRI and they need to be under good care and they need to be stable. Alopecia areata, we don't know exactly what causes it. We think it's probably a T-cell mediated autoimmune issue. This is something that is really, when I see this, it goes to a dermatologist. I don't treat it. Usually first episode is prior to 20 years of age. It usually waxes and wanes and burns out. There are mild cases just need some intralesional steroids and minoxidil, maybe PRP, sometimes that's worked as well. Severe cases really need a topical immune modulator. HT, in rare cases, if it's totally burned out, could work because it's non-scarring. And then as you probably saw in the recent literature, there's an oral JAK inhibitor called Olumiant, I can't pronounce it, that is out there that can help modulate this as well. Of course, there's a differential diagnosis with tinea capitis or other scalp conditions, trauma, scarring, hair loss. And under a microscope, you'll see, or under just a close evaluation, you see some exclamation point hairs. That's very pathognomonic of it. There are also unusual band-like losses you're seeing here. That's called epiphysis or reverse epiphysis. That basically it can look like a male pattern hair loss, or it can be below in the donor area that's lost. And then of course there's totalis and then complete universalis for all the hair loss of hairs. This is really a dermatologic condition. I encourage you to really look at all the full pathology of this, understand it, memorize it, learn it. You need to know scalp pathologies, especially you're not a dermatologist. You need to know this because if you don't understand dermatologic conditions, you're going to have problems. Traction alopecia is highly treatable for a transplant because it's something that's non-scarring. However, this is the big thing as you see, the differential diagnosis is FFA, CCCA. If you see loss of eyebrows, thinning, things like that, itching, burning, they have to have that. That could be FFA. We'll hear that in the next section. Also, if they have thinning in the crown that looks unusual, that CCCA, there's 30% of those, actually what looks like traction is actually CCCA. So if you're having crown thinning and the front, you need to have a higher suspicion for possible CCCA, especially if there's any like shininess or anything that looks odd. Your brain will start to look and go, hey, this looks like CCCA, this doesn't look like it. One of the things that can help you is the history. If they said, look, 15 years ago, I had tight braiding and I lost all my hair and never came back, that's indicating to me more traction. If they tell me, you know what, it's progressively getting worse, I don't remember any inciting event, it just gets worse and worse and worse, then that's more indicative of a scarring hair loss of some kind. And the other thing is not always pathognomonic, but it's helpful, is the fringe sign. What that means is if you see this lady, can you see there's a little bit of hair sitting at the very edge? Usually if it's FFA or CCCA, that whole front edge is wiped out. There's no residual front edge of hair. That's called the fringe sign. It is not pathognomonic, it's helpful to tell you that they have traction, not CCCA. Okay, so it's a sign for traction, not for CCCA. These are great candidates for hair transplants. However, it goes beyond the discussion group, is just to understand that when I'm transplanting into this area, African Americans have low density in the back. It's all about strategizing and telling their hairstyle so they don't wear, if they wear it totally relaxed, it may not create as much density. If they wear it kinkier or rounder or longer, they can get more density. So if they have great density, they can wear it any way they want. If they have moderate density, you want to leverage the way that their hair is. So this is the big heart of this talk. It is the core of the reason I put this lecture together is scarring hair losses. You cannot miss this. And you will miss it, but you cannot miss it. And these are the things that I need you to understand. So to me, a scarring alopecia is a trichologic emergency, which basically means you don't sit on this because once that field is being destroyed, it doesn't come back. It gets worse and worse and worse, and there's no exit on this. It's amazing. I hear these stories all the time. Oh yeah, you know, dermatologist saw me 10 years ago, and I saw them, they gave me some minoxidil, and I left, came back 5 years, and I was getting worse, I gave them minoxidil, they went home, like, you're a dermatologist. It's clearly screaming FFA. How do you miss this? Well, unfortunately, this is why you guys need to be a gatekeeper, even though you're a surgeon, to stay safe, okay? And so if you don't know what these things look like, I'll show you, but Google images, start to see it. When you see it, you can't unsee it, okay? We're going to show you some examples of this. So if there's a question, you need to do a biopsy, because if there's no question, it's clearly FFA, and you want to treat it, have the dermatologist treat it. I don't treat this. But if you have any uncertainty or if you want to do surgery, I need a biopsy that says this is not FFA if I'm really suspicious of it because I don't want a problem. Now, here's the problem with biopsy. It's contingent on a few factors. You need a couple 4mm biopsies. They got to be vertical and horizontal sectioning, and they've got to be in active disease areas. If you biopsy away from the problem, you won't see a problem. So where is the active disease? It's at the periphery. So if you have a CCCA, you want it at the point of the periphery. If you're seeing lupus, discoid lupus, there's a red border, you want to hit that border. If you're FFA, you don't hit down where it's all gone. You hit it right at the edge of the temple where it's starting to recede and have activity. You see active disease, it'll tell you a couple things. Do they have the disease, and is it active? Because if you have burned out disease where it's no longer active, then in general, theoretically, you can transplant with a few caveats. One is that it's ideally, they should be burned out for at least 2 years before you consider a transplant, but you can negotiate this a little shorter. I'm not saying you should. And if you did do it and the disease reactivates, the grafts will go away. So these are all issues and problems, okay? So this is so important, is that if you have any suspicions, get out of your hands and get it to a dermatologist. And in terms of the histology, what's interesting is I talk about FFA, I talk about CCCA, I talk about discoid lupus. Do you know they all look the same? It's a clinical diagnosis, but histologically they all look the same. They're lymphocytic infiltration. And if you can get this book, the Vera Price Cicatricial Alopecia is a great book for you to understand cicatricial alopecia. It's easy to get on Amazon. And then there's another classification called leukocytic, which is, as you can imagine, it's more of inflammatory in terms of white cells that could be infectious. For example, oftentimes follicular calvins is most common in African-American men in their teenage years, but I just recently had a patient had burned out FD who is mid-70s white. So it's not necessarily just because I told you the higher prevalence in that's if you're seeing someone out of that category, it can be. If they got purulent discharge, it's not recalcitrant, whatever, get them to a dermatologist before this becomes a problem and it can't come back. So let's look at this example. This is FFA that came to my office, and this discovery of FFA occurred in the 1990s. There's been a rising trend. As I told you, it's a loss in the eyebrows initially. There's this shiny appearance. The scalp just looks like a wave of loss coming up this way. The whole temples have been wiped out to the side. I hope you see this doesn't look right. If you can't see it, try to get this into your mind. Right, it's shiny. There can be telangiectasias. There can be a cobblestone appearance to the scalp.
You always have eyebrows? Are the eyebrows always?
Not always. Things are variable, but generally that's usually one of the first signs. As I told you, what I found is that there's a high correlation with sunscreens, and there, I think Jeffrey Dover has a list of sunscreens that have less of a risk. Because what's happening is some of the titanium or zinc oxide is getting into the cells and causing the damage and causing it to be a problem. I found to be a much higher incidence of those that do sunscreens every single day. Or they have a little bit of reaction to it, where there's a little bit of irritation to it, and they don't know it's burning them while they're doing it, and that can cause this problem. Now, it's not always the case. It can also be linked to skincare products, fancy things like that. Some studies have shown no causal link. I personally think, anecdotally, that there is a high linkage to irritation. So, CCCA is originally called hot comb alopecia because it was originally thought to be related to the styling products of black women, but it actually may or may not be. It went through a phase where the etiology was actually just genetic. There's a genetic link, a locus called PADI3, and now I think the pendulum is sort of in the middle, thinking this is genetic, that's incited by an epigenetic focus, such as a styling issue. Because usually I can elicit a history where they say they started using some kind of product. Now it could be anecdotal, but this is something that is very classic when you see it. If you see, especially a female crown that looks like this is CCCA until proven otherwise. And if they've got what looks like traction on top of this, you could theoretically successfully transplant the front, but I would assume that if that front is lost, even if they have a fringe sign and they have something that looks like this, I need a biopsy on the front. That's what I call that's what I call medium suspicion. It's medium suspicion, not because it looks weird. It actually looks pretty normal. But because it's in tandem with this, my fear is that this is a representation of this, and then I can't touch you. Or I shouldn't touch you until we meet all those criteria. Does that make sense? And this is something I didn't know my first few years in practice. Unfortunately, I didn't really encounter a lot of these. It's been a growing trend. But when I studied for the American Board of Hair Surgery, I had to study and learn all this. I'm like, oh my God, I'm on a mission to make sure this is part of my St. Louis course, this is part of the discussion. I actually have dermatologists presenting this, but of course I'm doing all the lectures here. Discoid lupus is usually a little bit of a red, scaly, patchy hair loss, burns out to white plaque, so eventually could look like either what's called pseudopelade, which is also known as footprints in the snow. Also, it could be a burn, people think it could be burned. It could look at like burnout lichen planopolaris. And as I said, 10% have systemic abortion. Lichen planopolaris or LPP, I transplanted this successfully, but again, this could reactivate. It's basically a form of lichen planus, and they're basically white, small, multifocal plaques. And these are all things that need to be under care of a dermatologist sooner than later. Don't sit on these kind of things. And if you have a question, something doesn't just feel right, there's no ostia, it looks shiny, it looks white, it looks a little red, a little scaly, something doesn't feel right, you'll start learning when you don't feel right, get it out of your hands and get it to a biopsy and get it in the hands of a qualified dermatologist. And obviously, besides the location of the biopsy, if you go to a bad dermatologist, they know what they're doing, that's just like going to a bad surgeon. So you have a good dermatologist, you have the right biopsy by the right dermatologist to get the right diagnosis. Finally, last category here is traumatic surgical alopecia. There's trauma, cancer recons, prior hair surgeries, linear donor scars. We know all of that. The reason I put asterisks to the last three are these things you may not know about, but these are all those popular surgeries in the 1990s that have become less popular today. So why do you know all this stuff? Is it for historical interest? It actually isn't, because you're going to encounter some of these patients. You don't know what the heck to do with them. You don't know what kind of blood supply trauma they cause or what kind of issues there are. So it's good to just go as an overview. I encourage you to look these over. Uri flap, I used to do this actually during my fellowship later on in 2001, 2002. But we were at the tail end of that being popular. This was really popular in the 80s and 90s. So Toby Mayer, I think, still does this in LA, but essentially Uri flap is a twice delayed TPO flap, temporal parietal occipital. They elevate, drop it, and then they bring it and put it up to the front, and it can look like a weird strip. You can see that example there. And then eventually when they lose all that hair back, they have this dense, weird hair that's going the wrong direction in the front with a blunted frontal temporal angle, and they've got nothing behind it. It's a little scary looking. Now, there are free flap TPOs that reverse the angle direction. Of course, you can argue all this, but basically these things are outdated for the most part, but you're going to see these. You're going to see LE flaps, which are small, short ones coming up. You may see very rarely these brandy scalp elevated flaps that are pedicle, also delayed flaps on the temporal artery coming up this way. There are many types, and then the ones that have, there's probably only one person still doing this, I believe in the world, probably a few. Patrick Fauché out of France, I think he's still alive, still works on this stuff, and he still does these, but essentially, I showed you an example where I fixed a scalp reduction slot deformity. If you think about it, if you've got a crown that's round and you narrow it, you're going to have a narrow band. Now, the way to fix it is called a triple flap repair, where you're rotating to recreate the whirl, but you're going to see some of these probably at some point, and it's important to understand what is a scalp reduction, what's a scalp extender. Extender, basically all it is a silicone clamp that goes underneath the skin, and what it does is like a tissue expansion, but it's a pretty cool device that Fauché invented. What happens is that if you can grab onto the hair-bearing scalp, all your stretch back is in your hair-bearing scalp, and in that area of non-hair-bearing that you reduced, it actually gets more contracted in rather than relaxed, and all your hair-bearing goes out. So it speeds up your ability to do a scalp reduction. It's a pretty genius device, but I haven't done that in 20 years, and I only did it in my fellowship. So the summary here is really understand non-scarring hair loss conditions, understand scarring hair loss conditions, understand when to intervene early, when not to operate, and really understand, even though they're of historical nature, the importance of these flaps reductions. This is about leadership and practice management. It's more of an esoteric lecture that has hopefully some pragmatic roots in it. This course is a big passion course for me, as you probably can see, and it's about vision. And so vision really begins with the idea that, hey, where the heck do you want to go? What do you see this as part of your career that you want to have? And if you don't, it's absolutely fine. At the end of the 2 days, you go, you know what? It doesn't make me excited. This is boring. Too much work. I have other interests. If you know what to leave on the table, what to take on the table, that's part of maturity. That's part of what's so important. And then if you don't know, I do this. I recommend this exercise. Really great. You can do it on your plane ride back if you want. It's called a hot pen exercise. Essentially, what it is, you take a sheet of paper or your computer, whatever, if you're digital, not digital, and you just spend 20 minutes to an hour and you write free flow. You can make it about your personal life, your professional life, and write anything you want, and then you start to crystallize what you want in 5 years. You want a family? Do you want whatever? I don't know, whatever you want. Just write what you want and let yourself get into the idea of that being your end in mind. Because if you don't have an end in mind, you don't know where you're going. If you don't have a direction, if Uber will take you, but you don't put a destination, then you don't know where you're going. So it really, if you think about the iPhone, which of course you know I'm a big Mac fan, I mean, that's genius. But I can imagine my life without an iPhone, okay? And it began with someone thinking about this and going, you know what? I have the courage to think different. You know, I wanted to do this course. I thought of it in one day and I said, let's do it. So, so this is the thing. I don't know if I'm doing it again, but it's really thinking big and going big and not worrying about what other people tell you about you can't do it or you shouldn't do it. It's not about them. They're either jealous of you or they have no vision. So this is about you. It's about what you want in your life and how you can go to get it. And you don't have to do anything you don't want. If hair is not interest you, that's not a problem. So for me, I also look at life as about constantly learning and growing. I do it because it's fun. Tony Robbins talks about this thing called no extra time. And or net. And what this basically means is I don't waste a lot of time in my life. You know, I get up, I paint, I do a lot of things. I learn languages as I'm driving. Don't do that if you're not good with it as an auditory learner. But I don't waste time. I love learning. And to me, it's not because I have to learn. It's because I love learning. I just love it. And so it's important for leadership. I always say, you know, I'm not a great manager. I've got great managers in my office, but I'm a good leader. I can lead them. I'm hoping I'm leading you to move forward. I'm always thinking about the next step. And mentorship is critical. And this is my mentor, Ed Williams. And what I saw with Ed was really cool. He was never a control freak. When the S hit the fan, he was always not blaming someone else. He was taking onus upon himself. And he always liked to say, you can inspire someone, you can't motivate him. This is one of his favorite expressions. Because I hope I've inspired you, but you know, I can't get up and make you do it because that's stupid. As I told you about, you know, Danny Meyer setting the table. I can teach you how to set a table. I can teach you how to cut a graft. I can't teach you to care to do it. I can't teach you to do the ethical thing. I can't teach you to do the right thing. I can't teach you to be passionate about it. I can't teach you to do the right thing for the patient. So I always say, be a mentor, find a mentor. Do what you think you want to do in your life and what moves you. Vance Elliott was my mentor who taught me hair. And you've got to find someone that can be your mentor in a way. And also, you know, what I loved about Ed was he never was angry about anything. He always chilled out. And that's really cool. I like what he said. If you can't control yourself, you can't control someone around you. And so to me, it's about really having this discipline in yourself to let people around you want to be like you. And these are great books that have inspired me. I like John Maxwell's leadership principles. He basically says people don't quit companies, they quit people. You know, they join companies, they leave managers. And that's really, really true. So we talk about training people in the front desk, not just to what they know, but how they can deliver that message, which is so important. What Maxwell says is, 8s can lead 7s, but 7s won't lead 8s. And what that means is, like, I got people who are smarter than I am around me, so I'm not saying just pure intelligence, but they need to be inspired to want to follow you, okay? And you can actually see who the leaders are in the room because people can gravitate to that person. And so what you want to do is lead your staff better, because if you can't lead them well, you're not going to have great staff, and that's really important. A few things that have made important impacts on my life are basically, you know, Daniel Pink's Drive and Start With Why. These are just ideas about getting to the purpose of what you're doing, why you're doing it. You know, I mean, clearly I'm not here to make $1 off you. I'm here to make sure that I'm losing money to be here, you're losing money to be here, but we're doing it because we're looking for the next turn in our life that may be a big thing. It may not be for you. Culture is a huge component to success. If you don't have the right culture, if your staff's not the right culture, you need to shift it. And the shift occurs from the top down. It doesn't occur from the bottom up. You cannot say, well, the person cleaning my office has a bad culture. It's inspired from where you're coming down. And that's really it's a top-down structure. Happiness hypothesis, this is written by Jonathan Haidt, and what he talks about is, if you're not happy, just stop doing it. Okay? If hair is boring to you, just don't do it. It's going to make your life miserable. If it's fun, you'll work harder at it. As you know, Steve Jobs said, if it's not fun, it's going to be too hard. No, you're going to quit. And so I hope this makes you happy. Teaching makes me happy. And this is what Mikhail Csikszentmihalyi recently passed away said. It's called flow, right? Flow is about doing something that makes you inspired and passionate, but it also means it's not so easy. It's got to be a little challenging. It can't be impossible. And so at the end of the day, we got to decide when to say no to something. I mean, hair may be a no for you. Maybe just another thing on your table that's just too much. Maybe it's a yes. And it's more important. Jim Collins talks about what he leaves on the table versus what he takes. But the sign of maturity is to say no. I don't want that. I'm not going to do that again. And yes means hey, it's great. But the one thing you need to think about with hair is that you have to have focus on it. It's got to be something that you're passionate about. Otherwise you have a stepchild mentality where it's just sitting there as an extra little menu item, and you go, okay, I can do some hair. It won't grow. My first few years when I did that, it just always stayed stagnant. You've got to put the effort to market it, to work on it, to do it. Otherwise, it's not going to go anywhere. And education's important. I go to education around the year. Obviously, you guys are here. I have to sell you the idea how important education is. I remember recently I was talking to actually a few years ago, I was talking to a friend of mine, and she's a dermatologist out of San Francisco, and just talking to her, I said, oh, you haven't been in a meeting with me, that's 4 years? She says, yeah, how'd you know? I said, because you're totally outdated just listening to you. I'm not even a dermatologist. I can just hear that you're not even with it. Meetings are critical. Last year I went to a meeting in DC, and I was just accidentally walking in to a meeting about fillers, and I found this new technique of doing these fillers, like, oh my God, this is life-changing. And it was just an accident, right? But whatever it is, you put yourself in enough positions out there, you learn things, you get some little pearls that make things big. As you know, I'm big into redundancy. You've heard my slides 15 times because you don't remember all this. When I do my work with my patients, I'm redundant. I say the same thing over and over again because I can't remember it. Socratic methods, how I teach. I challenge you to push your mind to think about things. And really, mastery is an asymptote. You get better and better, but you're never good enough. Okay? And when you're good enough, there's a good saying, when you're green, you're growing. When you're ripe, you're rotting. So you want to always be growing. And really look at what makes you different. What are the qualities that for a patient to want to pick you over someone else? If you don't know those, really think through it and define what's your unique selling proposition. And you got to put work on it. If you don't put work on it, the flower's not going to grow. Okay? You've got to put work on it. And the fact that you're here, you're already dedicated, spending 2 days, spending the cost that you spent to be here, you guys are obviously there. And it really is not just about me. Ken and I put that book together. Ken has totally different skill sets than I do. Amina has totally different skill sets than I do. The product I told you about, Vlad, is my business partner. Totally different sets of skill sets. Find people that you can marry your talents with, because you want to find people not redundant for you, that are really going to be a great fit to get better. And be careful of burnout. You know, really understand that, you know, there's only so much time in the day. If you're wanting to drive yourself to the point of just complete burnout, it's not good. But have fun. For me, painting is really such a huge part of my life. It gives me such joy, profound artistic release. And that's really where everything sits, is starting with passion. So I'm hoping I can ignite that passion within you, and I'll leave you with the final quote here. You've got to find what you love. Your work is going to fill a large part of your life, and the only way to be truly satisfied to do what you believe in is great work. And the only way to do great work is to love what you do. If you haven't found it yet, keep looking. Don't settle. Steve Jobs. So I hope I've inspired you to do this and motivated you. No, inspired you, because I can't motivate you. But what we're going to do here is more than happy to do some more lab work, and however long you want to do it. You paid for it, you want to do it, let's do it. But I thought this was a good break for some people that are really tired of lab. They need to get the last 3 lectures in. So if you're done, I think you know what we can do? Let's take some photos. That way, for those that want to continue lab, they can continue lab. Those that want to continue lab, they don't have to. Does that sound okay? Any questions or anything?
Question
Yeah.
about your day, your patients when they come to surgery. I know
Right.
you have lunch.
Yeah.
Lunch with them.
Uh-huh.
At what point do they eat lunch? And
Okay,
do you
yeah.
give them any more sedation?
Good question. So the way that it works is basically I'm finished with my portion of an LSC procedure by about 10:30. So my staff are still finishing dissection. They're starting placing, and then by about 12:30, they've done some initial placing. They set the patient up. They get a little bit more. They're able to give them like a little sandwich. They're able to eat that, chill out, watch some TV or do whatever, get on the phone, answer some stuff. And then about 30 minutes, an hour later, if my staff are finished eating, I'm done. The staff are back from lunch. Then the patient gets usually an oral sedative, like maybe Xanax or something, 0.5 milligrams per milligram, whatever it means that the patient needs based on weight and all that. And then they just sort of zonk out a little bit. They're already numb the whole day, so they usually don't get renumbed. But that is enough to hold them for the next 3 to 4 hours for graft placement until the day is over. From a FUE perspective, I'm usually done by about 11:30, sometimes 12:30, sometimes 11, so somewhere in that range, depending on the graft counts. And then after I'm done with that, I put in the PRP, and then right after that, they usually have finished sorting and trimming down. If they needed more ones, to take the 2s down to 1s, everything's ready to go and place into little piles to go. And then the patient has lunch then, and then they're also given a little bit of Valium or usually Xanax or something, and that knocks them out for 3 hours, and they're doing graft placement. So that's basically, so it's usually an oral after that.
Okay.
When do you start your day?
So the patient is there by 6:30. I'm there by 7:10. So 6:30, they have their PRP drawn. They have the PRP starting to process. They have their consents rechecked, everything. They have photographs not done. They're redone. If they need to, usually it's all done. They have their IV started, and they may even get a very early like oral Valium. Usually I like to be there before the oral Valium starts so that I can draw hairlines. I get around 7:10, and then I draw the hairline. I confirm the donor, whether it's an FUE grid or whether it's a strip, and then they finish preparing it, whether it's further shaving or shaving that area and taping up. I walk out, do a little devotional type thing, and then I come back 15 minutes later, and I'm ready to start. So I'm starting my case about 7:40, roughly. I'm done with my mark 7:15 to 7:20, depending on things. Like if I get there 7:10, I'll probably be done by 7:30. I get there at 7, I'm done by 7:20, 7:25. That's just getting the hairline done and preparing everything. It takes about 15 to 20 minutes to do hairline work and just finish shaping, not shaping, but I just say, here's my FUE grid, or here's my strip for plan, and I walk out. Then it takes me about, I give them about 15 to 30 minutes to get ready, and then, or usually 15 to 25 minutes, and then I come back and start. Does that answer your question?
Do you dye the hair at all?
That's a good question. I don't. It can be helpful, to be honest with you. I just don't want people to have like a skunk in the back if they're white hairs or something. I just usually deal with it. And usually with FUE, I can see the angles well enough that I just have to, what I've got to do is move my head a little bit. If you do want to dye them, it's better to dye them about a day before because like just for men, because if you do it the day of, it just darkens the scalp. Everything gets really muddy and nasty. So if you want to do the dye, you should do it a day before. Or if they're used to dyeing their hair, if they say, look, I like dyeing my hair, they should dye their hair no more than 2 days before because that way it's still really there. Because as you know, white hair as it exits, it's clear. So seeing the color that hits the shaft going down to the skin gives them direction of where to make the cut. So it does help, but I usually don't ask the patient, to go from white hair to black just because I want to make my life easier. But if they're going to do it, I want to time it well so that one, I can get the best harvest, and two, that they can't dye their hair for another 2 to 3 weeks. So it gives them a little time that when they can't dye their hair again, that they're not worried about it. I don't take the photos. You always obviously have to take photos, and my staff does it. If you want to know the angles, I didn't talk. I'm sorry, I have a lecture on photography, but it's basically frontal view. You want to get the hairstyles pretty consistent if you can. The hair color, the hairstyle. So you try to ask patients not come in blonde one day and black post-op, or short and long if you can. But it's their life, right? You can't tell them not to do it. But it's hard to make comparisons. Female hairstyles got to be somewhat similar. Take all the jewelry off. I take a frontal shot. Try not to be smiling. Try to take the glasses off if possible. Frontal view, no smiling. Frankfurt horizontal plane, you know what that is, right? And so 3/4 view profile. 3/4 view profile. Now that's standard facial cosmetic surgery. The other components that are helpful, top down, okay, and then crown backside and then crown back up. And what you want to do with the photography is try to match the before photos. So in other words, if they're down this far versus this far, because it's hard to get a landmark of exactly how far to go. To get before and after, especially when it's for social media, I usually say, look, go back and look at the before and match the degree of tilt so that they look the same. Does that make sense? With women, one other thing too is generally it's good to do the part in the middle. And if you're parting from one side, try to be consistent in your after photography. Another good thing is if you're doing scars, linear donor scars, you're dealing with a traumatic scar, you can also take close-up photography. Those are always helpful. You can obviously take down the exposure by a couple notches if it looks overexposed. So you can go and take specific items besides your standard photography. Always start small. That's probably the thing that Nicole talks about in the course that I have. She talks about, and Vance talks about it, and we give you some of those guidances that there's only so many lectures I can give. And it's just saying, look, let's do a 200 graft case. Let's do a 500 graft case. Let's do, and it may not, and eyebrows are very advanced. Maybe it's, you know what, I've got a guy with just a little bit of thinning in the front, and I just need to get in a few grafts. Maybe I'm going to give him 200 FUE grafts. I'm going to do, and it's not going to be lowering his hairline. Okay, I'm not going to go and try to get a temple point down. And he's got a good hairline. He's a little thinning there. Put him on some medical therapy. Harvest a little bit of FUE. Take a small strip. Do small procedures. Just get your staff feet wet. Get your staff feet wet. Those are to me big lessons that I would say in terms of broad categories of things.
Do you combine like a forehead shortening with the hair?
Yeah, I don't do a lot of forehead shortenings. I really have focused on hair transplants. I find it just, I almost always need to bring this in because aesthetically, women, when I sandwich this down, I have to fix this. So I wind up just doing transplants, almost all of them. I find it to be the best. But hairline lowering is not unacceptable.